Good evening, everyone, and good afternoon from UK. I welcome everyone on our platform Shield Connect. And today, the platform is sponsored with SAFG and RCOG, and the topic is addressing adverse outcomes in pregnancy by International Academic Exchange webinar from SAFG and RCOG. So before we start with the session, let me welcome our MOC for the day, Dr. Apurva Palam Reddy from India. Ma'am is consultant of reproductive medicine and cosmetic gynecology in Phoenix Specialty Clinic, Bangalore. And ma'am is director of International Fertility Academy and editor of decision making in infertility. So, ma'am, I hand over the session to you, ma'am.
Thank you so much, Shant. My sincere thanks to the entire team of SAFOG for having me over here today. And I must say, what a brilliant event, in this day and era of entire endoscopies, infertility, and sonographies. I think we are all forgetting that all these, advanced technologies are ultimately resulting in pregnancies which are more and more complicated, having women who are older age getting pregnant. And it is equally important for us to take care of these pregnancies and make sure that women come out of these pregnancies safely. Me as a fertility specialist, I have seen when initially we were referring patients outside that they had to terminate pregnancies midway because of extensive hypertension and a whole lot of other issues. So it really warms my heart to see so many countries and exceptional speakers from all over the place coming over to give a talk on these aspects. The president of SAFOG, Dr. Rohana, Secretary General, Dr. Yusuf Khan, the coordinators and chairs for our current sessions, Dr. Deep Datta from UK, Dr. Padmaraj from Nepal, Dr. Sadhna Gupta from India, and Dr. Jyoti Gupta from India. Welcome, everyone. And now may I request our president, Dr. Rohana sir, to take over and inaugurate the session, please.
Thank you, Apurva, for that kind invitation. Sir Professor Arul Kumaran, the past president, FIGO, RCOG, and BMA, Professor Edward Morris, the president RCOG, and all the others in the faculty today, and Dr. Narendra Malhotra, the director, international programs of SAFOG. Good evening and good afternoon to everybody. And I bring greetings from SAFOG to everyone. So I am delighted to see so many joining today's program. And I am very pleased to welcome everyone to this first SAFOG RCOG International Academic Exchange webinar. I thank and congratulate our dynamic director, International Affairs, Professor Narendra Malhotra, for organizing and making all the arrangements for this webinar and for involving so many leaders from the RCOG as well as SAFOG. Firstly, I thank the RCOG President, Professor Edward Morris, and the incoming President, Professor Rani Thakur, and all the other officers of RCOG for agreeing to have this joint RCOG SAFOG program and for giving all the assistance to it. And I take this opportunity to congratulate Professor Thakur for being elected as President-elect of RCOG at the recently concluded RCOG elections. As we are all aware, many members of SAFOG countries are fellows or members of the RCOG, and many are interested in obtaining membership of the RCOG. So I am sure that SAFOG members will be very interested and enthusiastic to participate in today's program with the RCOG. I am happy to understand that Professor Arul Kumaran, Professor Edward Morris, and Professor Dame Leslie Regan will be delivering the keynote addresses, and everyone will be eagerly waiting to listen to them. Let me also congratulate Professor Dame Leslie Regan for being appointed as the Women's Health Ambassador for England by the Department of Health. I also make it an occasion to thank Professor Arul Kumaran, who is our external advisor to SAFOG, for all his advice, guidance, and continuous support for the activities in SAFOG. Then I thank Dr. Deep Datta, Dr. Arina, and Niranjan from UK for participating. And I appreciate the contributions by the SAFOG officers, Professor Rubina Sohel, the past president, Professor Jaideep Malhotra, who is our editor, and Professor Bhaskar Pal, and Professor Yusuf, the Secretary General, and Dr. Rajan Pat, and Dr. Sadhana Gupta. I see that in today's program, so many issues which disturb the practicing clinicians are being discussed. It will be very informative and program and will help everyone to update their knowledge on safety in maternity care, recurrent pregnancy losses, obstetric deals, safe motherhood, and antenatal care. So before I conclude, I wish to remind everyone that SAFOG will be celebrating its Silver Jubilee this year. And the Silver Jubilee SAFOG Congress will be held in association with the annual Congress of Sri Lanka College of ONG in Colombo. It will be held from 30th September to the 2nd October 2022. The organizing committee has come up with an excellent scientific program for 3 days, and there will be several pre-Congress workshops in association with SAFOG committees and also with WHO, UNFPA, and UNICEF. So we are also happy that FIGO and A4G have already made their approval to participate in this Congress and support the Congress. The SAFOG will be very happy if RCOG will also join in the future. I know that there is some concern among many regarding the situation in Sri Lanka, but I must say that though there was a protest by the people in the recent past, now things have settled to a large extent, and the situation will be much improved by the time of our conference, which is in 2 months away. So the situation and the environment will not interfere with the Congress, and the organizing committee is getting ready for a grand event. So I invite each and every one of you to participate and make our Silver Jubilee Congress a memorable event for everyone. I look forward to seeing everyone in Colombo. With this, I would like to conclude and hand over to continue with the program to the moderators. Thank you very much.
Thank you so much, Rohana sir. I mean, it's been it's not a hidden fact that you have always stood by every event that the Indian organizations have conducted, and we are very happy for that. And from the entire team of India SAFOG and RCOG, we truly wish you peace, health, and huge success for your event in the coming months. With this, I think it's definitely an esteemed privilege for me to request our president, RCOG, Dr. Edward Morris, to kind of come over and address the gathering today. I think for all of us Indians, after we have finished our MDs, everyone has definitely at some point or the other tried to achieve.
Apurva, you're muted. Unmute.
You got muted. Apurva, you got muted. Yeah.
Over to you, Dr. Edward.
Thank you very much indeed, Apurva, and good evening, everybody. It's great to be here. I'd like to start by thanking SAFOG President, Dr. Rohana, Secretary General, Dr. Yusuf Latif Khan, Director of International Affairs, and of course, Dr. Narendra Malhotra. I'd also like to thank the chairpersons, faculty, honoured guests, and everyone taking part this evening, and also to the organisers for the amazing amount of work that has gone into these webinars. And it's a real honour for me and the rest of the team from the RCOG to be invited tonight. It gives me great pleasure to be with you all for this SAFOG RCOG International Academic Exchange webinar. And the aim of this webinar is to address adverse outcomes in pregnancy. The South Asia region, though, is really important for the RCOG. We've half our members overseas, And the highest concentration of those overseas members is indeed in Asia. We've got over 22% of our members located within the wider Asia region, and nearly 2,000 alone in South Asia. And that's why events such as these are so important to us as a college. Our South Asia RCOG International Representative Committees, there's the IRCs, are in India, Bangladesh, Nepal, Pakistan, and Sri Lanka. And they're all really active in supporting and engaging with our members in the region. And so this evening in particular, I'm delighted to be in the company of two former RCOG presidents, Professor Dame Leslie Regan and Professor Sir Arul Kumaran, and to see some RCOG IRC chairs from India on the panel this evening as well. But all good things must come to an end. And as you know, I'm coming to the end of my term as RCOG president, somewhat tinged with COVID, but nevertheless, I'm extremely sad to see it come to an end. But equally delighted that my RCOG Senior Vice President, Rani Thakur, who I'm sure many of you know really well, has been elected to be my successor as the 32nd RCOG President. I know she will be a fantastic advocate for your region and will work closely with SAFOG, the national colleges and federations of ONG in the region. Organisations like SAFOG, as I've said, are crucial bodies, and they bring together everyone in the region to work together to improve the health of women and girls. And after all, that's what drives us all towards excellence. So once again, thank you for inviting me, and I look forward very much to contributing.
Thank you so much, Dr. Wedgwood. And despite COVID and despite all the hurdles that have been there, it's definitely been a wonderful year for RCOG, and we are looking for more and more collaborations between both regions of the country. And yes, it's definitely no surprise, as I said, that 22% of your membership is actually in this side of the world. And now it's again my real pleasure and privilege to introduce and welcome Dr. Naren Malhotra, sir. I mean, sir has many caps, but I think I would want to kind of introduce him as mentor for the Gen Next doctors. I think half the country right now is being mentored by Dr. NM at one point or the other in their life. So I request sir to go ahead and give an outline as to how the entire program is being spread out.
So greetings, good evening, everyone. It's indeed a pleasure to be here and to see so many logged in the delegate group right from all the SAFOG countries. I've just been told every 7-8 SAFOG countries have been, including Afghanistan, all have been watching all this. Thank you for joining. This was conceptualized by Dr. Rohana and me, that as international SAFOG should have an image internationally. So we thought every 2 months we will join with one of the organizations and do some programs. So we did it with Iron Donald, we did it with FIGO, and we're now doing with RCOG. The next one is with AOFOG, and the last one would be with the Menopause Society, the South Asian Menopause Society. So that's how we thought that SAFOG will make a niche everywhere, and we'll have a lot of collaborative events. And I thank RCOG, especially Edward Morris and Rani Thakur for agreeing to this program. And we will. So before I go any further, I think Rani has sent a video message, and I'll request Chitra to kindly play that video message for all of us before we move on to the program.
Dear friends, I'm Rani Thakur, President for Global Health and President-elect of RCOG. I'm sorry I'm unable to join you today, but thank you so much for asking me to say a few words. Firstly, I would like to congratulate Professor Dr. Narendra Malhotra for organizing the SAFOG International Joint Webinar Series 2022. This is the fourth one in the series and is the joint RCOG SAFOG webinar. Thank you so much for inviting us. I'm really impressed with this collaborative concept of working together, which has been the ethos behind these webinars. The program focuses on adverse outcomes of pregnancy with speakers who are experts in the field, including two of our past presidents, Professor Arul Kumaran and Professor Dame Leslie Regan. In addition, you have none other than our President, Eddie Morris, who will address you at the beginning. I have no doubt that at the end of this webinar, you will be much richer in knowledge in this area. I look forward to further collaboration with SAFOG when I take over as president of the RCOG. As they say, if you want to go fast, go alone. But if you want to go far, go together. Together, we can achieve a lot more for women and girls we serve. Enjoy this webinar today. Thank you.
Thank you, Dr. Thakkar. Thank you for your lovely message. If we want to go far, we have to go together. That is the punchline which we all have to follow and believe. So now I would request coordinators, Dr. Niharika and Apurva, to invite our past president of RCOG, Sir Arul Kumaran, to give his thoughts on this. Introduce him, please.
I think Professor Arul Kumaran sir requires no introduction at any event across the globe these days. We've read sir's books, learned from it. I still remember the first time I met sir in Liverpool RCOG. Such a charismatic person and such a zeal to actually inculcate the ideology of giving proper healthcare for women and making sure labor is the safest for all of them, and to pass it on to the next generations. I think that zeal is absolutely commendable. We are so privileged and honored to actually have you here today and be a part of the discussion, sir. We would definitely are eager to know about all your thoughts on the current topic today.
Good afternoon, and thank you very much for the kind introduction, Apurva and Niharika, who are conducting the show. Thank you, Dr. Hattotur, for the kind introduction, Narendra for inviting me, and to my past presidents, Leslie Regan, and of course, Eddie Morris, the current president and the future president to join, as well as many past presidents of SAFOG, including Rubina. So my task today is to talk about the global view of maternal mortality before we start the session. So I might just share some of the slides and give this short, brief introduction about maternal mortality, concentrating finally on the SAFOG region. So the topic given to me was about global perspectives in safe motherhood. Although I'll talk about global perspectives, I will focus finally on the SAFOG region. First, I would like to I had no conflict of interest. I would like to thank Professor Rubina Sohail, from whom I got a number of slides related to SAFOG region, and Mercedes Bonnet from WHO for global perspectives. So safe motherhood was in the card for the United Nations for a long time, and as we know, in the millennium, they had MDG 5, but the whole thing is focused into SDG 3.1. The Millennium Development Goals said we had to get 75% reduction in maternal mortality, which was not really achieved due to a number of reasons, but considerable reduction was obtained. Now we are converted to SDG 3.1, and it looks like this. The MDG we wanted from 1990, 532,000 deaths to 303,000. There was a 44% reduction instead of 75%. Now, SDG 3.1 says we must have a global maternal mortality ratio of less than 70 per 100,000, but no country should exceed 140 per 100,000, so which is achieved by many countries already. So our main aim should be not to talk about numbers, but to see whether we can avoid any maternal death at all. Now, looking at the global map in 2015, if you look at the horizontal bar, the countries which have the highest maternal mortality in sub-Saharan Africa and Afghanistan, and then you find the next is actually coming to the regions of India, Bangladesh, Pakistan, Nepal, that's the concentration there. So our area, the Suffolk area, is really focused on maternal mortality reduction. Now, maternal mortality reduction, although is number 3, there are number 5 also deals with women's health or gender equality. But many of these things are interlinked. Unless there is no poverty, zero hunger can be eliminated, good health, we can't achieve maternal mortality, including clean water and good climatic problems can be solved in addition to good employment. Now, not only we are talking about maternal mortality, today's discussion will really look at various other aspects, but the burning questions with women's health are the lack of contraception for those who need it, cancer-related deaths, physical and sexual violence, and the emerging problem of non-communicable diseases, which give rise to 28% of maternal mortality. The top 20 countries, as I mentioned earlier, is mapped out here, and Suffolk countries, except Sri Lanka, is in the zone. So we have to focus on all our efforts. Now, India, for example, if you look at the maternal mortality ratio, doesn't come into the map at all. Number 53 is Pakistan, which is about 176 per 100,000. India dropped the maternal mortality 132 per 100,000. And the latest is about 112 per 100,000. So they are done well and continuing to do well. But unfortunately, in terms of absolute numbers, India gives rise to total staggering number of deaths because of the population, next followed by Nigeria, Pakistan, etc., etc. That is because if you look at the population map, 6 countries other than China put together equates the population of India: Indonesia, United States, Brazil, Pakistan, Bangladesh. So it's absolute numbers contributes to the deaths because there are 27 million births each year. Now, mapping the improvement of global maternal mortality, we did a survey by McKinsey's and Imperial College London, and the studies implemented by countries which were successful in reducing maternal mortality were studied. And we thought of suggesting to the governments to consider the successful policies and request the NGOs, professional organizations, and private sector to assist governments to translate these strategies into action. So what are the strategies? Pakistan was able to bring down the maternal mortality by community outreach and also contraceptive prevalence. India, investment in quality availability of maternal health care services, which helped to reduce maternal mortality rate by 75% because hospital institutional deliveries went up. Nepal, legalization of abortion, in addition to contraception and misoprostol for PPH. Bangladesh, family planning, and so on. So if you take it Suffolk, but you can take the other countries as well, contraception and safe abortion care becomes important area. So there are 3 areas identified by our survey. And there are 3 baskets of care. One is contraception, which we can reduce mortality by 30%, safe abortion care by 15%, and the rest 55% by proper maternity care, tackling obstetric emergencies. Now, in terms of implementing this cost, this is a complex table, but I'll explain to you. If you take the women between 15 to 45 in a country, that is the targeted women, for example, first one, Morocco, is 8.2 million. And to give emergency obstetric care, they spend 44 million. So per person expended money is less than $6. Tamil Nadu, 24-hour services, 2,000 additional nurses, training and equipment. 22 million was spent with 16.4 million between 15 to 45. The money spent is $1.3 per woman. So in other words, the money you have to spend to bring down the maternal mortality is not a severe amount if you really think about it, looking at the population who are exposed and concentrate on the 3 baskets of care. But the strategies has to put into action, and there are 5 points to consider. First of all, we can't do it alone as hospital or professional organization. There should be a coalition formed, and we have to leverage all the groups like the professional organizations, the NGOs, and the government. Second, we can't do everything at the same time. There are not enough staff, so we have to focus on selecting and implementing few targeted initiatives one by one. So first it might be contraception, then safe abortion care, obstetric hemorrhage, preeclampsia, like that. So it's a national implementation of targeted initiatives. Third is strengthen the ownership at grassroots level. So the hospitals and clinics should feel that they have to do it because they are bringing the mortality themselves. And fourth, continually innovate to maximize available resources. Like in India, they are allowing taxis to take pregnant mothers to the place where they would give birth, and they are given the money to pay. And even private institutions can do a delivery, they get a fixed sum. So you have to innovate and also have some public-private partnership. But nothing will improve unless there is accountability by consistently measuring how many are delivering, how many maternal deaths. And you have to reward them in some way by recognition, not by money, but recognition. So these 5 are crucial if you want to implement the principles. So if we get back to the map, as you could see here, the 3 baskets of care, family planning is number 1, 30%, safe abortion, 13%, and the rest about hemorrhage, infection, preeclampsia contributes the rest. So we have to look at all 3. There are long-term goals as well, like education, relief of poverty, and so on is quite important. So about emergency obstetrics, there's going to be a talk later on. You can see hemorrhage is the highest number of maternal deaths, which has some issues related to antenatal care because of reduction of anemia, then hypertensive disorders, and infection. These are the 3 key areas, and you can bring about reduction by focusing on these 3 areas to reduce. But if you look at a pie chart or a longitudinal bar chart, you can find hemorrhage gives rise to the maximum number of deaths, and this is not different in SAFA countries. Annually, 15 million women globally have postpartum hemorrhage, 75,000 die. Others get morbidity like anemia and other problems as they go along. And the best thing is to prevent it, because preventing an early treatment can avoid maternal deaths in nearly 80–90% of the people. If you take the postpartum hemorrhage rate over 500 milliliters, it's about 6%, and over liter is 2%. But you can reduce this by proper uterotonic drugs. This is the woman trial results of 483 women who died in that trial. Mainly it was late presentation, maternal anemia, non-availability of blood, and poor infrastructure, not enough staff, and not enough transport. So we had to work our way through 4 different areas. How can we provide quality healthcare, which is affordable, accessible, and available? Secondly, we had to stimulate desire for care. We had to educate the public to see how by community health workers and so on, and by advertising, by social media. Third, you have to think about financial affordability. And fourth is physical accessibility. So if there's a barrier, we have to overcome the barrier. If they can't reach us, we have to reach them and provide the care. So Sri Lanka has a fantastic model where the midwives reach at every community level, the midwife visits the pregnant mother. The next one I mentioned was about family planning and the postpartum intrauterine device or an implant, which is a long-acting reversible contraceptive, forms a fantastic model to reduce maternal mortality. Copper IUD, if the woman wants it out in 3 years, you can take it out, or if she wants to use it for 10 years, she can do that, because spacing the family also helps in reducing preterm birth, growth restriction, etc. The money spent on contraception is very minimal, although lots of money is sent from abroad, from non-governmental agencies to the health departments in these countries. The amount spent is very much low, about 3.2% of the total budget. So we had to focus on that. And maybe we can really speak with Professor Leslie Reagan, who is going to champion the women's health here in each country, how we can model the care. Now, these are from Rubina, looking at the maternal mortality rate in Afghanistan, Bangladesh, India, Maldives, and so on. As you can see, Sri Lanka is 29, Maldives is 53. The rest of the countries are targeting around over 100, and India is 112, which will come down with progress of time. But if you look at the individual countries, Afghanistan, obstetric hemorrhage leads to about 27%, and institutional delivery is 58%. So in other words, we have to increase institutional delivery, manage anemia very early in pregnancy, and treat postpartum hemorrhage so that you can bring down the deaths. Bangladesh, again, 47% deliveries in health facilities, and PPH remains the main cause of maternal death. In other words, we have to see whether we can increase institutional deliveries and also provide active management of third stage or management with uterotonics so that we can avoid the hemorrhage deaths. Bhutan, again, PPH responsible for 43% of maternal deaths. They are doing some wonderful programs like Safe Motherhood, increasing institutional delivery, improving quality of service, preconception package, and so on. But I think two things we have to focus on, think is contraception and postpartum hemorrhage management. In addition, wherever abortion is feasible, safe abortion care. Maldives, again, maternal mortality is 53, but hemorrhage is 32% of maternal deaths. They're also doing a wonderful thing because of increased institutionalized delivery, but contraception is, again, slightly lacking, and that has to be sorted. Nepal, again, 186 per 100,000 live births and 25% attributed to postpartum hemorrhage. So that is, again, a major problem. So PPH prevention program is there. They are using Uterotonics, which is misoprostol in remote areas, but we can enhance that further. Pakistan, again, obstetric hemorrhage is the most common cause of maternal mortality, about 21%. And they are doing misoprostol as well as good referral system if possible. Sri Lanka, again, a low maternal mortality still remains, PPH remains the leading cause of 12.7 maternal deaths. And if you notice, the institutional delivery is 99%. So that is why it is possible for them to overcome the problem. In addition to clinical drills they perform, supervised by obstetrician, and availability of transfusion 24/7. So the country situation in India, we can look at it, although it has come considerably down. 20 to 25% is again maternal due to postpartum hemorrhage, and institutional delivery are going up. They are doing number of programs with emergency obstetric care. This is a paper looking at 1997 to 2020. That's about 23 years. 1.3 million maternal deaths occurred between 97 to 22. That's a phenomenal sum, and 23,800 in 2020 only. And with most occurring in poor states in India, 63%. And also in the prime of their life, 20 to 29 years. And some states like Assam, Uttar Pradesh, Uttarakhand, Madhya Pradesh has the highest, surpassing the estimate 113. So these are the areas they have to focus on. And whereas some like Maharashtra, Kerala, and Tamil Nadu are doing well. And leading cause of maternal deaths, obstetric hemorrhage, according to this study, 47% in the higher, in poorer states. And infection and hypertensive disorders of a lesser magnitude. So even in a country, we have to focus on how can we overcome the problem. Well, we know that Uterotonics, if you don't give any Uterotonics, 24 per thousand will lead more than 1,000 milliliters. And if you give Uterotonics, you can cut it down to 8 per thousand. So 992 will be okay. So to give that, we have been trying misoprostol, but recent meta-analysis says it's not effective compared to long-acting carbetocin, which has an action of 2 hours if you give it intramuscular, and it's heat stable. So can we take it to the periphery because it can be given intramuscularly? Another drug which is well known is tranexamic acid, which is also heat stable. And if you give it immediately, there's a 70% reduction in improvement of survival. So whether we can give tranexamic acid and carbetocin together in combination, and tranexamic acid can be given intramuscular because we know every 15 minutes delay, there's going to be a 10% reduction in survival. So this study shows that intramuscular, you can get it in 3.5 minutes, the pharmacological levels will be reached. Oral preparation takes 1 hour, so we have to depend on intramuscular to give it. Now, there's a large study by Ari Kumarasamy from Birmingham going on. We're studying 337,000, called the E-Motive study, looking at giving everything together, massage the uterus, Uterotonics, tranexamic acid, IV fluids, and examination for genital tract escalation. But in places like Uttarakhand and others, where we can't really have many doctors, we can at least train people to give IEM tranexamic acid and IEM carbetocin, and should be made available so we can reduce the maternal mortality, and also focus on contraception, because 30% reduction and of the complications in obstetrics, 30% reduction of hemorrhage can be done by proper Uterotonics. So it remains a priority, and we have to ensure healthy lives and promote well-being. And we have to avoid, by preventing and managing obstetric hemorrhage, contraceptives and safe abortion care. And we have to concentrate on NCDs as well as we go along. So I'd like to conclude by saying the global target is maternal mortality less than 70 per 100,000. And the national target should be 2/3 reduction from the 2010 baseline. And 2030, no country should have a maternal mortality rate of 140 per 100,000, which will be achieved by India, which is already achieved by other countries. But the target need not be 140, but by not zero. And we have to also focus on where there is human-made disorders or natural disasters, which you can look at these million words cannot describe what's in the mind of this toddler, 2.5-year sister protected by 4-year-old brother in Nepal. So Nepal needs quite a lot, and also war-torn areas, as you could see. So I would like to quote Martin Luther King's words: "There comes a time when one must take a position that is neither safe nor political, but because of one's conscience tells one that it's right." So we have to really focus on things and improve the governmental interventions to bring about a change. And again, Mahmoud Fatahullah's words: "The women are dying not because the societies are yet to make the decision and their lives are worth saving." So I think as professional organizations, the SAFOG and the RCOG can work together and also provide the woman the human rights to be alive, well, and after the pregnancy and childbirth. So not only they should survive, but they must thrive, not suffer from complications of pregnancy. Thank you very much indeed.
Thank you so much, sir. And it was indeed a great pleasure to listen to you today. And I'm always in awe of you. And whenever I listen to you, I go and read all the things you tell us. And I'm so, so grateful to meeting you online today. And with this, we'll begin our scientific program for now. And for the scientific session, I would invite the chairpersons for today's session. And our first chairperson for today's session is Dr. Dib Datta. He's a consultant OBGYN, NHS England. He's been honored nationally and internationally with many awards. And he's also been a guest speaker in many of our conferences. We welcome you here, sir. Our next chairperson for today's session is Dr. Professor Padam Raj Pant, who's been the professor, Department of OBGYN of Tribhuvan University from Nepal. He's heading the OBGYN department, also the chairman of the Department of Advanced Surgery and IVF Unit. We welcome you here, sir. Our next chairperson for today's session is Dr. Sadhna Gupta. She is the co-chair of SAFOG NCD committee, also been the FOGSI representative to SAFOG, ICOG governing council member, and past vice president of FOGSI. Welcome, madam. Our next chairperson is Dr. Jyoti Gupta, who is a director and consultant fetal medicine from Noida, and she's been an associate member of the Royal College of OBGYN London, Fetal Medicine Foundation, and Society of Fetal Medicine India. Welcome here, madam, and I invite the chairpersons to introduce our first speaker. Today, we are addressing adverse outcomes, and it is one of the steps towards strengthening SAFOG countries towards maternal fetal health.
Dr. Jyoti Gupta, you can carry on because you're there.
Hello everyone, greetings to everyone from India. So I'm great to be part of this webinar, and I have an extreme privilege to welcome Dr. Edward Morris, sir, to give his talk on safety of the women. Sir is a national and international role. He's a past president of Royal College of Obs and Gynae, and then he's a vice chairman, Academy of the Medical Royal College. Till date, he is the president and vice president, quality RCOG. And he has a special interest in advanced management of menopause, provision of tertiary labor endometriosis service, quality improvement. We welcome you, sir. Looking forward for your talk. Thank you.
Thank you very much. Well, it's great to be here. I'm just going to share my screen. Hopefully that's working. Can someone confirm that you are seeing that all right?
Yes, sir.
Fantastic. Great. Hopefully that's in slideshow mode. Doesn't seem to be at my end though. There we go. Great. Well, thank you for inviting me to talk here today. I've already thanked the organisers for such a fantastic welcome, and I hope very much that the talk actually complements Professor Aul Kumaran's really good talk showing the scale of the problems with maternity safety globally. And I thought I'd share with you some of the work that we're doing in the UK, but also how a college like the RCOG goes about it. But if we start on the principle that the UK is one of the safest places in the world to have a baby, but it's not as safe as it could be. And that's what drives our desire for improvement. We do actually have one of the highest numbers of stillbirth amongst high-income countries in the world. And that's a very interesting measure of that is the fact that clinical negligence costs in the UK are going up and up. And if you look at this rather stark figure that actually the NHS paid £2.4 billion in settling negligence claims. And actually the cost of maternity care on its own is £3 billion. So we think there should be a shift in where the money goes. And our regulator says that many of the maternity units in the UK require improvements. And those of you who have worked in the UK will be very familiar with things such as staff shortages and gaps in the rotas. But the thing that particularly concerns me before being president, but much more as president, is that if you're Black in the UK or South Asian, you have an increased chance of experiencing either maternal mortality or other adverse outcomes. So what can we do? How can we go about this as a college? Well, I've divided the functions of a college into data, improvement, education, workforce, collaboration, and advocacy. You can do it in many different ways, but I've chosen to use these to highlight my talk. So let's talk about data first. Anyone knows me knows I love to talk about data. And anyone who knows me knows I'm really keen on this project that was started by my vice president predecessor, but was very much left to me to look after while I was VP alongside President Leslie Regan at the time. And the underlying principle with Each Baby Counts was that no normally formed term baby whose mother goes into labor should suffer death either during or shortly after birth, or suffer a severe disability as a result of an event in labor. And this project ran for a long time and really has driven improvement in the UK. But if you look at the main reports that have been published, pretty consistently each year, it was found that roughly 1,100 babies suffered an adverse outcome as a result of term labor, and where care could have been improved. And that's a pretty stark thing to see. And when you look at would different care have changed the outcome, over the duration of the project, which was looking at what was going on in the UK, things didn't really change. And so we felt, as we transitioned from Leslie's presidency to mine, that the right thing to do was to start doing something about it. When you look at the things that were going wrong with Each Baby Counts, that it was an interplay of many different factors. It wasn't just one thing. Quite often we were getting the finger pointed at us saying we didn't know how to interpret a CTG. But when you look at the themes in Each Baby Counts, it's many different things. And these are 5 examples of things that can impact on an adverse outcome. And you can see that some cases had all 5 as an element of the adverse outcome, where some just had 1. And we all know that. All those of us who work on labour ward know that it's an interplay of these things. So Each Baby Counts was very important. The other way that we collect data is through the National Maternity and Perinatal Audit, and that continues. And I really do recommend you have a look at that, because that shows how good quality data accessed frequently can really help the analysis and understanding of what's going on. And I didn't plan this to interact with Sir Arul's presentation, but I just extracted the one thing from NMPA that really shows, and that's the collection about data around postpartum hemorrhage. And we see very clearly that there's a huge variation in the proportion of women experiencing a 3rd or 4th degree tear or postpartum hemorrhage of 1,500 mils or more. And this graph is known as a funnel plot. And it shows each dot is a unit in England or Wales, and rated by the number of deliveries at term in that unit. So you've got some very big units there of 10,000 term singleton births against much smaller units of 1,000. But you can see that there are some units have much higher incidence of postpartum hemorrhage than others. And it's identifying those problems, saying, why are you an outlier here? What makes you particularly bad here? And that's the power of data. You can then direct your attention to those units that aren't doing quite so well. Another really interesting thing, just one slide on this, is the effect of maternal obesity. We know we're living in a maternal obesity epidemic. When I was last in India, I spoke on obesity and women's health. And the NMPA shown very eloquently that the greater the BMI, the greater the chance of a baby being born with an APGAR score less than 7, and the greater chance of there being an obstetric hemorrhage. So again, the power of data. But we need to do something about it. We can't really admire the problem. We have to actually get on and do something about it. So we got funding for a project called Each Baby Counts Learn Support, and that's embedding ways in which units can actually learn how to improve the care that they deliver. It sounds a simple thing to do, but you know as well as I do, as working obstetricians and gynecologists, that when you go to work, you don't go to work with the same team on every shift. And so opportunities to improve have to be embedded in the hospital so that people can learn how to deliver the safest care. And this project has just finished. It's got a very well described set of tools to show how people can learn as teams in their trust. We also set up towards the end of 2019, the Tomis National Centre for Maternity Improvement. And that's hugely concentrating on innovation, using personalized assessment of women's care during their pregnancy, but digital in a way that the mother is carrying a digital patient care record and collecting the data automatically. And effectively, this lives on her mobile phone up in the cloud. But wherever she goes, someone is able to access high quality data so that they can see what's happening to her pregnancy as an individual. And that's really exciting. It's very early days, but do keep your eye on this because it's a very exciting project. And I think shows the way the future carrying of hospital notes will be actually on that person's mobile phone. Those of you who know Rani Thakur, our president-elect, know that she's passionate about preventing obstetric anal sphincter injuries, or OASI, and she headed up the hugely successful OASI Care Bundle project that ran whilst I was vice president. And this project has shown that if you use the bundle, then you have a reduction in the overall OASI rates, you have a reduction in vaginal OASI rates, and this does not influence the need for episiotomy or cesarean sections. So that's really exciting and has led very much to the next version of it, which is called OASI Care Bundle 2. No surprise there, but that's about scaling it up, making this pilot of 16 units in OASI 1 something that could be scaled up around the country. I know Rani is going around the country talking to units, saying that this is where you should be, and I have every anticipation that this is the sort of thing that should now spread globally now that we've established its efficacy. And finally, with the things that we're doing to improve care in the UK is the Avoiding Brain Injury in Childbirth. And this is an incredibly exciting project. We spent quite a few months championing funding from the UK government to really concentrate on how can we reduce the incidence of brain injury and death during childbirth. And essentially, it's about two things. One is better detection and response to fetal deterioration. So that's not just the CTG. It's not asking the question, is the CTG okay, but actually, is the baby okay? Is the mum okay? And it's really reinventing the partogram, if I was to summarize it in one particular way. And it's very exciting. We had a webinar on it last night, and the link for that will be on the RCOG website. So I do recommend that you can see that if you can. And the other arm of this is dealing with the increasing problem of the obstetric emergency of intrapartum fetal head impaction at cesarean section. And we know that that's an increasing problem within the Western world, and it has been a problem, well, it certainly is a problem globally, and we're trying to address that in the UK. But as you know, if you're an MRCOG or thinking of becoming an MRCOG, education is absolutely key when you're addressing safety in maternity. In fact, our regulator, the General Medical Council, have safety as one of the key domains that we are trained in and therefore assessed by to remain a GMC registered doctor. And so naturally, it's in the RCOG curriculum. We have these communities in practice, capabilities in practice, and you'll see there the second bullet point that we are training people within the curriculum that have to actively engage in a culture that promotes safety. We also have key skills within those capabilities in practice, quality and safety being absolutely key to that. And again, you will learn about that if you're training in O&G according to our curriculum. But of course, as my Vice President colleague, Janice Reimer, used to say, that exams drive, or assessment drives education, and we have the RCOG exams, that's DRCOG and MRCOG, and those have those clear elements of safety. And the best example within the exams, and certainly within the OSCEs, the part 3, is the fact that the Labour Ward Board, that's the ultimate test of ability to prioritise your background knowledge, how you use all the resources around, and how you would steer the team. But also in the college, we're about lifelong education, CPD, team training. They're great for learning drills and skills and safety. The various RCOG courses that are going on both online in the post-pandemic world, but also here in Union Street, where I'm lecturing to you from at this moment in time. But we also work with the NHS in the UK, but most of all, facilitating an environment to thrive. Now, workforce is something that I've been particularly passionate about to get right as president. We have a fantastic vice president, Joe Mountfield, who is leading this work. And I'm just putting it simply in one slide. And it's about having a workforce where people want to come into O&G. I wanted to come into O&G. It looked like the most amazing career to have. And so therefore, we want to encourage the obstetricians of the future. We are responsible for training the obstetricians of the future, but helping the trainers out there to do that. So giving them the skills, giving them the education to train and to motivate. Once you're in post, it's supporting you. We have our membership activities, we have CPD, we have the meetings, and we have an evolving library of online resources. And we're soon to have a new whole electronic system for presenting those to you in a much more curated fashion. We also have career support throughout your career in obs and gynae. So if you're a member, there's lots there for you. But we're also about making sure that certainly in the UK, the workforce is the right size, it's in the right place, and they are available at the right time. Moving on to collaboration. Now, Leslie set up, when she was in post, along with the Royal College of Midwives, and I've been really proud to carry on this, the One Voice Common Purpose Collaboration. And these are the key providers of health in women's health, maternity, and neonatal care. Along with bereavement and loss, which I know Leslie's going to talk about in a minute. And this is absolutely vital to show that when we are representing the women we look after, we do that in a common way. And I would really encourage in your countries, this is a great way to tell governments what they really need to do to improve care. But when we look at one of our centres within the system, and Tim Draycott, Vice President for Clinical Quality, helped set this up. It's a collaboration in the Tommy's Centre of institutions such as RCOG, Tommy's, the Midwives, and our Women Voices Network, but also key academic institutions, because a college can't do these things on their own. They need everybody to be involved, and from collaboration comes strength. And if we're talking about strength, one of my proudest things, and I didn't have this planned as president, was production of the COVID guidance. Everybody came together. It was a massive team effort. And I'm so grateful to everybody that helped out, because I know those guidelines were used around the world. We had those guidelines downloaded nearly 7 million times during the pandemic. And on our Facebook, Instagram, Twitter, etc., 25 million times. So it shows that, and India, by the way, was our second biggest user of our COVID guidance. So thank you for your engagement with that. And that shows that when you collaborate and produce something powerful, it will improve safety around the world. And finally, advocacy. Advocacy is one of those things that we do as part of our work in the Royal College. A lot of people want to know what advocacy really is. And it's really representing the women, members, fellows, trainees, and anybody linked to maternity and women's healthcare. And that involves advocating for our workforce, getting money from other people to support the work of the college and other people so that we can do things like collect the right data, the NMPA or Each Baby Counts, so that we can publish reports or guidance so that people can see what needs to be done. But also implementing improvement. I showed you the work we're doing in improvement, but that needs funding. The RCOG is a charity, and we have to go to people to get funding for those projects. It doesn't come from a bottomless pit of money. And also the other side of advocacy that we don't go pursuing additional funding, but this very much comes from membership fees and other resources, is the work we do in external affairs. That is absolutely key. That's our media team and our policy team. And if I expand on that a little bit, when we look at the recent successes that we've had, so I've spoken to you about Each Baby Counts, that has influenced the way the NHS works. That has influenced the way politicians think about maternity and baby loss. And that's key to improving women's health. If you can influence politicians and the decisions they make, that influences government and therefore funding that goes into the health system. And there's other two organisations within the UK who have also been influenced by Each Baby Counts. It also, our call for women's health strategy that Leslie made during her term as president has now borne fruit. Not only do we have a women's health strategy launched a week and a day ago, we also have a women's health ambassador in Leslie. We're so proud. It's fantastic to have her as ambassador because that means things can only improve. And that shows through persistence and lobbying, you can effect change in your country. Other successes such as telemedicine for early medical abortion in the UK and banning virginity testing and hymenoplasty, getting those things through legislation. But also encouraging the government to fund all the work that has been done. Now, the big number there of 95.9 million, that money doesn't come to the college. That has gone to the health system to expand people working in obstetrics and gynecology. Again, showing that the RCOG, influencing, slip of the tongue there, influencing the UK government to put more money into maternity. So that shows how if the RCOG works in the background, it can really make a difference. But part of what we do, and I spoke about this earlier, was our global work. And Aral has done that because Aral, as a global champion for the work we've done, who's kept on as past president, knows the value of this and has demonstrated this to you all this evening. We have the RCOG Centre for Women's Global Health, where project-based work and advocacy for countries and also the women in those countries is done. And you can find lots about that on our website. We also have starting to support curricula in different countries around the world and helping to support career progression. And we have a successful project in Iceland. We have a pilot not far from starting in India and also in UAE. We have our examinations, which are a key way of spreading the messages of the college and making it easier for you to become a member. We have our online examinations for part 1 and part 2, but also increasingly the ability to do our part 3 around the world in different centers. I'm so excited. We're going to have exams in Chennai and in Kolkata coming up very soon for the part 3. And we provide membership support globally and the production of guidelines that we occasionally try to make suitable for other countries. And we have the IRCs, and I spoke about that earlier. Our IRCs represent the college and develop networks in those countries for all our fellows, members, and increasingly our associates. And thank you for the support the IRCs give back to us as a college, because without this two-way relationship, it really doesn't work. And especially during the pandemic, that was particularly important. IRCs also keep education, training, people wanting to become MRCOGs a key part of their work. And we do meet with you regularly. In fact, we had a meeting last week that was brilliant. We saw all the IRC chairs at that meeting, and it was fantastic to catch up. You will all seen this slide before, but it really shows that we really are a global college. Yes, the UK has just over 8,000 members, but look, there are nearly 8,000 members around the world as well. And I'm proud that the region that I'm talking to today has that biggest chunk, that 22%. So thank you for hosting this webinar, because it has been completely brilliant. I've got lots of people to thank. This list is long, but I see I'm running out of time. So I just want to say thank you for listening. This is the college in Union Street. It's where I'm speaking from today, and I'd be delighted to welcome any of you here. Thank you.
Thank you, Professor Edward Morris. Thank you very much. Yes, we are all waiting to come to this college. 3 years back, CEFOG celebrated the CEFOG RCOG Day in the old college building, and what fun we had, academics and fun. And for next year, we are planning in May, June to be in this college for a CEFOG RCOG Day.
Well,
Dr.
let's
Jyoti,
look forward to the fun then.
Yeah, Dr. Rubina is there. Dr. Rubina, we are planning that.
Thank you, Dr. Morris, for this wonderful insight on the different initiatives taken by the RCOG. And each baby counts, and safe and respectful maternity is a right for every woman, and it cannot be compromised. Thank you, sir. Thank you, sir, for this wonderful talk.
Rubina, your comments, please. Dr. Rubina, past president CEFOG, is here, who actually started the CEFOG RCOG 3 years back.
Yeah, a very good day and a very warm welcome to all of you. And I am really, really excited about this webinar. And Narendra, thank you very much for organizing everything that you did today. And thank you to RCOG team and the CEFOG team who made it all possible. As you said, we are really looking forward to be in UK at RCOG for the South Asia Day that we host every couple of years. And Edward, you have made a very, very good presentation and put everything in perspective from the point of view of the countries of the South Asian region. What are the opportunities? What is the way forward? So really delighted to hear you. Thank you very much. And I look forward to hear from Leslie, because she's our ambassador for the ladies. Thank you very much.
Apurva, carry on. I think, yeah.
So Dr. Jyoti here.
Jyoti,
so I would like
carry
to,
on.
I would like to carry on, and I'd like to take this opportunity to invite our next speaker. Can I have the slide, please? Dr. Resli Legal, Madam will be talking on modern management of RPL. So, Madam is an honorary secretary of PIGO and professor in head department obstetrics and gynecology, St. Mary's Hospital, Imperial Royal College London, Director Recurrent Miscarriage Services. She is the chair of RCOG Abortion Task Force, chair of Wellbeing of Women's Society, and non-executive director of NHS Resolution. We welcome you, ma'am, and looking forward for your talk. Thank you.
Can you let me share my screen, please? Thank you. Thank you. Okay, thank you very much indeed for including me in this lovely webinar. As Eddie will remember, when I was president, there was often this discussion about how it would be much easier if I moved over to Asia and rang into Regent's Park, or now Union Street, a couple of times a week. And in particular, my colleagues in India used to insist that I should have an office there in Mumbai or Kolkata or Delhi. There was a bit of a fight about which city. And then as the then CEO, Ian Wiley, said, well, that's no good, he says, because then we'll have all the other SAFOG countries complaining. And Eddie, I'm sure you've had the same, well, I know because you've said so, the same warmth of a welcome from all of our colleagues in SAFOG. So it's lovely to be here. If you'll excuse me, I'm not going to repeat all the names today because they've already been repeated several times. But it was lovely also to hear from Arul Kumaran, one of our past presidents and a mentor to me. And also, Eddie, I loved hearing about the work that's come out of the COVID guidelines. I mean, I have forwarded the COVID guidelines to, I can't remember how many hundreds of different people wearing my FIGO hat. And so it's lovely to hear that you've had so many millions of downloads. But it also made me reflect on when we were sort of, I was getting elected, one of the things that I remember sharing with you, Eddie, was that I wanted to make the RCOG the go-to place for information. And I think that your COVID cell has certainly managed to get a most amazing accomplishment out of a terrible pandemic crisis. So my congratulations. Now, I'm going to talk about something I've talked about for many, many years, because I'm always been fascinated by why it is that miscarriage or pregnancy loss is the commonest complication of pregnancy. And yet it's only been very recently that we've understood very much about it. And it's an enormous problem being a miscarriage sufferer. And I'm trying to look at it from the woman's point of view, because she's got to cope with the personal bias of clinicians, anecdotal evidence, exacerbated by the social media and the World Wide Web now. It's emotionally extremely vulnerable time. She's got a biological clock. And of course, we clinicians do love our small, uncontrolled studies of substance X or rhubarb, whatever, and find it very difficult to randomize and control trials of treatment, which is why I think we've been in such a backward state for so long. So it's the commonest complication of pregnancy, and the vast majority of cases are due to aneuploidy or chromosome abnormalities in the embryos. I'm not telling this audience anything they don't know. You know all this very well. I want to spend just a moment talking about definitions, because there's been heated debate in the UK and across the world about whether recurrent miscarriage should be 3 or more losses, which affects about 1 to 2% of the population, or whether it should be 2 or more losses, which of course affects 5% of the population. And that may not seem like a big jump from 1 to 2 to 5, but of course it's a difference between investigating 1 in 50 or 100 couples and 1 in 20. So it has a massive impact on the healthcare resources you've got. Whichever definition you choose to use, I think it's really important that you ensure that the data that you're citing to demonstrate that what you're proposing is evidence-based is really based on data for either 2 or more or 3 or more. But you know all this, that there's very significant economic costs, which are probably the tip of the iceberg, because we recognize that many, many losses are occurring out in the community. And as we're going to see a bit later on, there's massive psychological sequelae for both partners. So there are some skeptics who still say that, well, it's just bad luck. But this is a study that Katie Clifford did many years ago now, when she looked at our very considerable database, which looks tiny in compared to what it's got on now. But this was 5,000 women who'd had 3 or more losses. And the interesting thing was that if you look back into their past obstetric history, they've got all sorts of other problems in addition to miscarrying early. They had a much higher incidence of fetal abnormalities requiring termination. They had a higher incidence of stillbirths and neonatal deaths. And possibly most importantly for our subsequent understanding of the mechanisms of miscarriage is that of those women who had had a previous live birth prior to miscarrying repeatedly, that pregnancy was often complicated by prematurity or fetal growth restriction. Now, you may say, well, of course, we all know that. But when Katie was doing her PhD with me, we didn't know that. And everybody thought that those problems of prematurity and IUGR pregnancies were something quite different from early miscarriage. And we now recognize that they're part of a spectrum. Now, I'm not going to have time to talk much about late miscarriage, but I just want to remind everybody on this webinar about how rare it is. I see a lot of it because we have a specialist service at St Mary's for late losses, but you should investigate all late losses, because after 12 weeks, it's very unusual for women to miscarry. Less than 2% of pregnancies are lost after 12 weeks. And it's very important also to collect good data about how the late miscarriage presented. It's going to be very different pathology if there was a painful labour or a preterm rupture of membranes compared to a painless labour and a sudden expulsion of the baby. But you'll be amazed how many clinicians fail to realise this point. And I would like to emphasise that placental pathology is invaluable. And if I'm conscious of the fact that in the SAFOG countries, many people for religious reasons don't wish to undergo a post-mortem, but please share with them how important it is, your patients, that they agree to a placental pathology examination, because it can be invaluable. And my last comment about late miscarriage, because I'm going to concentrate on early now, is that because of the magnitude of the problem, is that women who have a late miscarriage have often got multiple pathologies going on. So don't just look for maternal thrombophilia and say, oh, right, she's got this. we'll treat that. Carry on looking even when you get a positive on your checklist, because she could also have placental insufficiency, she could also have endometritis or infection, and she could also have a structural problem like cervical weakness or an intrauterine septum. So keep looking. Four different categories to tick off before you can say she's not got, you've investigated properly. So in this short space of time, I'm going to give a whistle-stop tour about some of the things which I think have been most interesting over recent years and also most controversial. And you can read the slide as well as I can. So I will just try and gloss over some of those just to draw your attention to some of the most recent data. Now, the thing about the RCOG, as you've heard from Eddie, is that we're very proud of our guidelines. In the world of recurrent pregnancy loss, there are 3 guidelines currently in press: the RCOG, the American College, and the ESHRI ones. And they are very, very different. In fact, they bear no resemblance to each other, which is rather strange. The RCOG guideline, currently in press, but about to be revamped, has got 18 pages. The ASRM practice guideline is a short one, 9 pages. The ESHRI one's got 151 pages. And you do wonder how much a busy clinician can afford 151 pages of text, very small font as well it is, when they're actually faced by a couple with miscarriages. So I'm just glad to say that I've already talked about the definitions, but the RCOG Green Top Guideline, which has been under development since the beginning of the pandemic, or no, before the pandemic, is hopefully going to be published before the end of 2022. And this gives me an opportunity to thank my co-authors, Raj Rai, who works with me at St. Mary's, and then Sotirios and TC Lee from Hong Kong, and also to give a shout out to Sotirios because we've just appointed him as a new consultant in our fertility and recurrent miscarriage, or rather reproductive medicine unit. So we look forward to welcoming him to the team at Imperial now. And the other thing I just wanted to share with you, and I can see Rubina nodding at me here, is it's a very heterogeneous problem, as we've already discussed, or I've already mentioned, and everyone you see wants to have a positive test. The most difficult clinical conundrum I meet is trying to persuade a couple I've investigated at great expense and in great detail that not having a problem is a good thing and that they're much more likely to have a successful outcome. Most couples want to have a problem. They don't realize that when you solve that problem for them or treat it effectively, that doesn't make them immune from having a miscarriage, from the commonest causes of miscarriage, which is a chromosomal abnormality, because chromosome instability is incredibly common in human embryos. In fact, it is bizarre why humans make so many duff embryos, and nobody really understands the mechanisms whereby the maternal endometrium prevents accepting most of them. So although miscarriage is commonly caused by aneuploidy, we know that actually the number of abnormal eggs that get fertilized is far higher. So there is something innate in the maternal immune system stroke metabolism that allows, or I should say uterine microbiome, that does not allow many of the chromosomal embryos, abnormal embryos, to implant. That's a subject for another day. But historically, of course, what we always were told to do is that we should actually screen the parents for karyotyping abnormalities, because 1 to 2% of them might have a translocation. But I think we've now realized that this is a very expensive way to not get very far, because even if you do have a balanced translocation, your advice should be to try and get pregnant spontaneously, not to pursue IVF and pre-implantation genetic screening. So on that note, I just want to include one other slide before I move on to another topic, because I'm asked this question more times in a week than I'm asked about anything else. And that is, I'm a miscarriage sufferer. Should I go now and have IVF with pre-implantation genetic screening? And the answer is no, because it doesn't increase the live birth rate in recurrent miscarriage women who are able to get pregnant spontaneously, and it doesn't reduce the time to achieve a live birth. Occasionally, it may be valuable in counselling couples where they've had all of their embryos have been abnormal repeatedly, and they may choose to have oocyte or sperm donation. But the best chance for miscarriers who can get pregnant spontaneous is natural conception. And what's the future of genetic screening for recurrent miscarriage? Well, I think we've got to get away from all of that, looking at the parents completely, because there are now very exciting data from an Israeli and a Spanish group showing that we can now identify cell-free DNA in maternal blood in the first trimester of pregnancy as early as 7 to 8 weeks. So wouldn't it be fantastic if the woman comes along to your pregnancy loss clinic or your early pregnancy unit, has a miscarriage, and then you can quickly and in the space of a day identify whether that pregnancy or miscarriage was chromosomally euploid normal or aneuploid abnormal. And then, of course, you're not going to investigate the aneuploid ones because that's random bad luck, but you would then put your resources into examining and investigating the euploid ones, which would mean then we could probably investigate all women who miscarry, which would probably be a real step forward. Now, these are two pictures. They look rather similar, but you'll notice they're rather different colours. And they're two pictures on the left-hand side of a septate uterus. And there I am looking up into the uterine cavity. The septum is marked S in the middle, and then the right tunnel going up to the right corneal orifice on the left of the screen, and the left corneal orifice obviously on the right of the screen. And on the other side, or the right-hand side picture, you see something that looks quite similar, but it's a different colour because it's atrophic. And this is a very similar picture, apparently a septum, but of course it's secondary to intrauterine adhesions and an atrophic uterus. And although there has never been a randomized controlled trial of recurrent miscarriage patients who've had septal resections, and here on this slide you can see, I hope, that there is this overarching fundal or dome-shaped myometrium here, which allows us to say that this is not bicornuate, this uterus, it's actually deeply subseptate. But if you resect those subseptate uteri, put 2 coils into the cavity to help keep the walls apart whilst you regenerate the endometrial lining in double quick time with a 4-week course of HRT, you can get a live birth rate, which is very significantly higher. And so our practice now at St. Mary's, the clinic that Raj and myself and Sotirios are running, was that any woman who's had 5 or more losses routinely gets hysteroscope, because it's interesting how often the imaging doesn't pick up a significantly narrowed cavity, which can be improved. Now, what about progesterone? It hits the newspapers at least once a month in London, or in the UK, I should say. Does it actually improve early pregnancy outcome? There's lots and lots of newspaper bulletins that like to persuade us that it does. And I think it's important because, of course, the potential benefits are enormous because the cost of intervention is low. It's very easy to get hold of progesterone. It's got a very good safety profile. And of course, the woman can administer it herself as a vaginal pessary. We no longer give them injections, which are terribly painful intramuscularly. So there's every reason to want this to work. But if we look at the trials of first trimester progesterone, they are a bit disappointing. So there was 2 major studies, the PROMISE study, which was a prevention study, looking to see whether women with recurrent miscarriage conceiving naturally benefited by having progesterone supplements in early pregnancy. And then there was a rescue study called the PRISM study, which is looking at the role of progesterone in women with threatened miscarriage. And what I want to emphasize, and why I've kept the slides so simple, is that the PRISM study was about all women with early pregnancy bleeding, whereas the prevention PROMISE study was about carefully categorizing recurrent miscarriage women. But the outcomes were very clear. The PROMISE one showed there was no benefit if you recruited women with 3 or more losses who conceived spontaneously. The PRISM study reported a very small benefit of progesterone in a subgroup of women with early pregnancy bleeding. And I just think that's important for us all to remember when those patients come in waving those bits of paper from the internet at us, because as you know, and all the data experts, of which I know Eddie is one, will actually keep reminding us that when you do subgroup analysis, you're answering a very different question, or you're trying to answer a different question from the one that you asked and when you were structuring the trial. And it is a very small subgroup of the women with early pregnancy bleeding. There was a lot of interest in luteal phase progestogens during the conception cycles because it's thought that they may possibly have a benefit via an immunomodulatory mechanism. But I still think it's going to be of limited benefit when we recognize that 50 to 70% of miscarriage patients or miscarriages are chromosomally abnormal, and that the commonest cause of having a low progesterone in early pregnancy is because the embryo is abnormal and the wrong crosstalk is going on between the embryo and the mother's endocrine system, which means that the progesterone is not being produced. So here we've got thrombophilias and fetal loss. You know there's a lot about this: acquired, phospholipid syndrome, and all the inherited ones, which seem to, you can add to this list almost every time you turn around and pick up Nature, which I don't do very often, but people keep pointing out the inherited thrombophilias that they're recording. So the phospholipid syndrome is this triad of features: the lupus anticoagulant, cardiolipin antibodies, and the beta-2 glycoprotein 1. There's been a lot of, in women with miscarriage or thrombosis or thrombocytopenia, there's been a lot of criticism of the studies for phospholipid syndrome. I think a lot of the problems are our laboratories are poor, actually, at getting really good prevalence data. I still think in our labs here at St Mary's, the prevalence is still 15%. So that's 1 in 6 or 7 of the couples that we see, which is significant. Now, if we go back to those 3 guidelines I showed you, they all agree that phospholipid syndrome is an important treatable cause of miscarriage. And the RCOG guideline recommends that women with their first trimester miscarriage or with more than 1 second trimester miscarriage should be screened for phospholipid syndrome. And all of the guidelines do recommend low-dose aspirin and heparin for these women, because the live birth rate untreated is as low as 10%. And over 75% for those treated, if you then rule out any of the other causes of miscarriage. And I think it's rather beautifully summarized on this slide of Raj Rai's, which is some time ago now. But here we're looking at a pregnancy survival chart from 5 to 41 weeks. And here you're looking at women who've had aspirin and heparin. The blue is aspirin alone, and the red is no treatment. And you'll see there's this massive cutoff at 13 weeks. So I hope the Doppler and the scan experts are now saying, well, how can these anti-platelet and anti-thrombotic medications, aspirin and heparin, be changing things so dramatically when in the first trimester of pregnancy, evolution has designed that there's very little blood flow to the embryo? Well done for coming up with that comment, because of course we now realize that the phospholipid syndrome, like all the other thrombophilias, are probably misnamed. It's a mechanism that goes far beyond thrombosis. By the time you've got a blood clot, the damage has long since happened. So we think that the mechanisms are that the phospholipid antibodies affect the way in which the uterus or the endometrium decidualizes. It certainly affects trophoblast function and results in poor invasion. And effectively, the heparin is not an anticoagulant. It's actually salvaging the potentially damaged placental cells and allowing them to implant. And that, of course, explains why you have things like growth restriction in the 3rd trimester and placental dysfunction then. Quickly looking at the genetic thrombophilias, because I get an enormous postbag asking about these. The factor V Leiden, if you're heterozygous or homozygous for it, increases the woman's risk of a venous thrombotic event quite significantly. But only in about 50% of the pregnancies does it seem to lead to problems in the actual pregnancy or the fetus, such as growth restriction or an abruption, preeclampsia or whatever. And that's probably, I think, when the baby inherits that mutation too. But it's important to remember that it's very important to treat those women, because they need to have protection from the venous thrombotic events, even when they've got past the first trimester miscarriages. And there's a very similar story to be had with the prothrombin gene mutation, which is less virulent, if you like, or less prevalent. And only about 25% of those pregnancies get affected by late pregnancy complications. But these women also do much better with low molecular weight heparin. And then we now know that the MTHFR gene mutations are actually requiring treatment with high-dose folic acid, probably for life, because the gene mutation is not going to leave you. And that also increases your risks of venous thrombotic events in later life. And more recently, the PI1 plasminogen activator inhibitor mutation is particularly prevalent in women with polycystic ovaries. And these women also respond very well to low molecular weight heparin. So thrombin is a very interesting thing. We think it just forms clots, but it actually has a very, very bad effect on trophoblasts. It increases angiogenesis. It increases apoptosis or programmed cell death of the trophoblast, which is not a good thing if you're a little embryo. and it reduces trophoblast invasion. So it leads to defective implantation. So how are we going to detect it? Because we can't really put a telescope inside and have a look at all those things at the microscopic level. So the thromboelastograph, which Raj and I have developed over time in our research labs at St Mary's, I think is a useful tool, because the left-hand side of the graphical picture that it prints out is reflecting thrombotic tendencies, and the right-hand side of it is the dissolving pathway or fibrinolytic pathway. So just look here at the red in the middle of this envelope in this patient who's, I've made up the name, so I'm not showing patient data. Look at that shape of that red thrombin generation there in a normal thromboelastogram, and compare it with this one, which is a woman who's got a raised clot amplitude. So she's got raised inflammatory parameters that we can detect before she's even got pregnant and in early pregnancy. And these women with this picture actually respond very well to higher dose aspirin from the time of the pregnancy test being positive to about 32 weeks. And this is very different. This is a thromboelastogram with a prolonged or impaired fibrinolytic pathway. So they're not dissolving the microclots in their circulation so well, very often seen in women with polycystic ovaries, which probably explains why we've never been able to correlate the hormones in polycystic ovaries contributing to miscarriage. It's actually via hemostatic mechanism. These women don't respond to aspirin, but they do respond to low molecular weight heparin. Now, immune challenges have been talked about. Well, Leonardo da Vinci worked out that it was an extraordinary thing how a fetus grew inside another human being without getting rejected like any other transplant should be. Peter Medawar put it on the map, and he got the Nobel Prize for his thesis on immunological tolerance in pregnancy. And if you can still Google him speaking at his Nobel ceremony back in 1960, which is a very interesting insight into science as it was then. But still, despite the lack of evidence, we see these pictures or these headlines in our newspapers and magazines all the time. My body's trying to kill my baby. Steroids can prevent up to a third of miscarriages by controlling killer cells, which I think is a very dangerous concept. And if we look now historically at immune testing and reproductive failure, there have been an enormous number of things that have started off being thought of as immune factors, but very few have survived the test of time. I've talked a little bit about phospholipid syndrome, which of course was an immune factor when it was first identified. I wrote my thesis about APCA and found that it didn't work at all, which was incredibly difficult to publish that it didn't work. And then we've got the NK cells, which I don't have time to talk an awful lot about. But I would remind you that there are an enormous number of clinicians across the world who still think that by immunomodulating pregnancies at the time of conception that they can improve outcomes. And I think it's fair to say with the exception of aspirin and heparin and possibly progesterone in some women, there's very little evidence that this is the case. And you just need to remember that uterine NK cells, the red ones at the top, are totally different to the peripheral blood NK cells, the blue one at the bottom. The NK cells in the uterus don't have any resemblance to them, and yet most women get their NK cells checked by having a blood sample taken out of their arm. So as Peter Brody and Ashley Moffat and I said in a rather naughty editorial a couple of years ago, so if you compare uterine and NK cells with peripheral blood ones, it's a little bit like trying to compare red minicabs going around the M25 with the black London taxis going around Trafalgar Square. I'm a bit tongue-in-cheek there, but you get my drift. Despite all this, and despite the evidence that there do appear to be higher levels of uterine NK cells in miscarriage women, the data to show that suppressing them with all sorts of systemic immunosuppressants just doesn't exist. You ask anyone who's advocating for it, and you ask them to show you the data, there is no control data. And of course, there is a growing body of evidence also happening in our courts, and certainly in the UK, of women who've been damaged by systemic immunosuppressants, particularly during the last couple of years with COVID around. So I think it's really important when we're talking about the immune system and pregnancy loss that we don't do any harm. There's no evidence that NK cells are harmful during pregnancy. The blood tests are not informative, but they will cost your patient about $1,500, so about £1,200 sterling and whatever equivalent that is in your currency. and there is a potential risk of serious side effects from immune suppression. So I would say it's potentially hazardous, and there is no evidence to say that it has a role in the treatment of reproductive failure. So I need to draw to a close very soon. I'm just going to share with you or remind you this very, very old slide. We all know that fertility decreases and miscarriage increases with age, but I think we're sometimes very slow to recognize that our societal reproductive patterns have changed immeasurably over the last couple of decades. So these are the advancing maternal and paternal age at conception. And there was a point at which on the 22nd of September 2016, which I remember very vividly because it came onto the Radio 4 Today programme, and it was the day that we launched the Tommy's Miscarriage Centre. So 6 years ago, almost exactly, when actually the number of babies born to mothers older than 35 eclipsed the ones less than 35. I mean, that's extraordinary. That did not happen in my mother's or my grandmother's generation. So we're really up against it. And I think my favourite comment is we're changing the goalposts all the time. And then there's advancing paternal age. We didn't used to think it was important, but now we recognise that it can be, and that sperm DNA fragmentation rates, when they do increase the risks of miscarriage. And on the right-hand side is this little list here of all the factors that can increase your sperm fragmentation. But then again, look at this, this meta-analysis of the effects of sperm DNA on miscarriage rates, and actually look carefully at some of their conclusions there from Lynn Robinson and the team in Birmingham and Sheena Lewis from Belfast, because what they show is that the treatments for sperm DNA fragmentation with antioxidants don't seem to change outcome. But possibly the biggest problem we've got, bigger than COVID as a pandemic, is the global pandemic of obesity. And we know that obesity has an effect on every aspect of reproduction on the mother and the baby, and it certainly increases miscarriage. My second most difficult conversation that I have at least half a dozen times a week is persuading women with a BMI of over 30 or 35 that it's going to really affect the way they reproduce. They don't like hearing this, but I've discovered various ways in which one can discuss it now, and hopefully get them to understand that it induces inflammatory markers both in the ovary and in the endometrium, which really have an adverse effect on reproduction. You'll be very aware of much of the work from Jessica Farron and Tom Bourne on post-traumatic stress and the depression levels following miscarriage, and how we tend to underestimate the psychological impact of pregnancy loss. It's very, very damaging for many, many women and their partners, and can actually trigger post-traumatic stress disorder. And I'm just glad that we now talk about this, even if we can't resolve it all completely. So I mentioned the Tommy's Miscarriage Centre, and I think that's important because for the first time we managed to persuade the players in the UK to pull together and to do things together. And I think we've already demonstrated that by making sure that people don't carry on working in their little potting sheds on their own, we can travel farther and faster. I've always believed that if you don't mind quite who gets the credit along the way, you can achieve a lot more. I want to pay tribute to David McIntyre, who's a scientist who's done an enormous amount of work, because the Tommy's team at Imperial have focused very much on the microbiome, because we've got a lot of scientific expertise in that. And I think it's really interesting because I think although we used to think about infections as organisms in the blood, we now realize that in fact bugs or microbes maketh man, or perhaps we should say they maketh woman. So 95% of every cell in our body is made out of microorganisms, and they have a key role in human health, but particularly reproductive health. So I can't spend any time sharing with you the data, but I can tell you now that there is about 4 or 5 different microbiomes in a pregnant woman. She's got a vaginal microbiome, a uterine one, she's got an ovarian one, she has a placental one. And then, of course, if I was a real microbiome expert, I'd say, God, that's really daft, Leslie. It's nothing to do with all that. They only develop their microbiomes because of what these women are eating. So there is an enormous amount of emerging data to show that your gut microbiome might actually be the thing that predicts whether you miscarry or have some other adverse pregnancy complication. And if that is the case, How can we modulate it? I think there's going to be a lot of very exciting data to look at in the future. So what I think the Tommy's funding is already demonstrating is that we can generate study results much faster. We can then translate those into practice because we're doing the science of this. Another group is doing the interventions of treatment. It gives you prestige to leverage other money. And I think importantly, and I say this now as someone who's aging a bit, you need some succession planning, and we are now training the next cadre of experts. So we'll have a sustainable legacy, not just something that was there for a while someone was interested. And I think that it means that we've got a much more holistic approach to miscarriage in the National Centre. I'm just going to leave you with my thought that I really do think this is probably going to be the future and will resolve the tussle between who should we be investigating if we start to harness this incredible science of being able to work out which is a euploid embryo and which is an aneuploid embryo, and then focus our attention on investigating why a normal embryo couldn't make it. And I think we'd then be able to use our resources much more effectively. And as some of you will know, one of my sort of mantras in my professional life has been, we miss a trick when we don't get women to understand what they can do to help themselves. And I was interviewed by somebody a few weeks ago who said to me, what do you think is the most useful thing you've done? And I said, oh, without doubt, writing a paperback, which is cheapest chips that you can get on the internet, to tell women about why they've suffered the commonest complication of pregnancy. And you know, I still get letters every month from people who say, hello, Professor Regan, we've never met, and now I don't need to come and see you because I now understand so much more about it, and it's given me a lot of confidence. Women are incredible advocates and ambassadors if you give them information to work with. Thank you so much for listening to me. I think I've run over time. I apologise, and been lovely to see you. I can't help getting enthusiastic about a subject I'm very passionate about. Thank you.
Thank you, Dr. Leslie, for this wonderful and crisp talk on the different pregnancy loss. And it is quite a challenging task to manage such patients, like as they are economically and psychologically devastated. And thank you so much, Dr. Leslie.
Pleasure. It's Ravina.
Okay, shall we move forward to the next talk? So may I have an opportunity to invite Dr. Rubina Sohail, who will be talking on obstetric bills for the Suffolk countries. Professor Rubina Sohail, she is a professor of obstetrics and gynecology and consultant at Hamid Latif Hospital, Lahore, champion of sexual and reproductive health and rights, pioneer of kangaroo mother care in Pakistan, chair FIGO committee on women facing crisis, and she has been awarded a Young Gynecologist Award 1994 and a Farsioji Addendum in 2019 for work to improve maternal and neonatal health. We welcome you, ma'am. Looking forward for your talk.
Thank you very much. Can I share my screen, please? Thank you. A very good day to everyone, and I'll start by talking about Leslie. What a beautiful presentation. I was into recurrent miscarriage. I have forgotten what I wanted to talk about. Excellent. I have never heard such a beautiful talk on recurrent miscarriage before. So thank you very much for that and opening our eyes to a subject which is extremely important for all of us. You know, the session started with the talk on the importance of the maternal mortality and what are the parameters in the South Asian region by our very own Professor Arun Kumar. And I thought that was a very important topic because in South Asia, in low middle income countries, mothers are still dying from things that they should not be dying from. So during childbirth, mothers are dying and neonates are also dying. And that is what brings my topic of obstetric drills in the SAFOC countries into perspective. And I think that it is very important to see what can be done. Now, my presentation is going to just touch upon, because the time is very short, I do realize, so it's going to touch upon the maternal and neonatal mortality situation in South Asia, training of OBGYN, what are the current needs, what is the role of obstetric drills, and what is the way forward for all of us. Now, we all know that there has been a lot of work all over the world in reducing maternal mortality globally, but it is still estimated that about 295,000 maternal deaths are taking place every year, and most of these maternal deaths are taking place in the low middle income countries, and South Asia takes a lot of burden of this maternal death. When we talk about maternal death, sometimes we forget that about 20 to 30 times maternal morbidity is happening along with one maternal death. And that is why it is very important to put systems in place which are going to not only help us reduce maternal mortality, but also help us reduce the maternal morbidity. Now, if you look at the babies, 1 in every 35 babies born in South Asia is dying within the first month of life. South Asian countries, more than one of them, have the highest rates of neonatal mortality in the world. A child born in South Asia is 9 times more likely to die in the first month of their life as compared to a child born in a high-income country. But also the fact to be noted is that they are twice as likely to die than babies born in Middle East and North Africa, where there's conflict and a lot of problems are ongoing. Even the rate of newborn death is double than them. So that is really a cause for concern. So we are having actually in South Asia huge public health challenges in terms of maternal and neonatal health. And when we talk about these challenges, we have to look at the fact that one intervention which is going to improve maternal and neonatal health is improvement in the quality of care. So it is not only about the type of care that we are going to provide. So for example, in Pakistan, when Millennium Development Goals were our target, Pakistan achieved a significant improvement in antenatal care in terms of numbers, but there was no dent in maternal mortality. And one of the reasons that there was no dent in maternal mortality was that though the number of antenatal care had improved in terms of numbers, but in terms of quality, antenatal care had actually not produced a major dent. So quality of care, I think, and quality improvement is the need of the day if you want to save the mothers and the newborns and if you want to meet the Sustainable Development Goals. I think when I talk about the Sustainable Development Goals and the need to reduce maternal mortality and morbidity and also the neonatal mortality and morbidity, we have to look at the changing scenario of the training in obstetrics and gynecology, which has been happening over the last couple of decades. And if you look at the fact that our residents and our trainees, and this is not only in the low middle income countries, actually it is happening in more developed and higher income countries as well, that the load of the number of deliveries, the vaginal deliveries, vacuum, whether faucets are actually decreasing all over the world. And the type of OB/GYN training that the residents are experiencing has changed substantially what it was when we were being trained. So there are greater number of cesarean sections, there are more multifetal deliveries, more patients are going home earlier. There are issues with consent, with privacy and ethical issues in terms of providing hands-on skill to the young residents. So the learning opportunities for our trainees has significantly reduced as compared to before. Another reason for the decrease in the learning opportunities for our trainees is in the change in the number of duty hours. So when we were being trained, we used to do 30 hours of duty, and then we would have an evening and night off and then come back after 48 hours and do another 30 hours. And that seems almost inhuman now. But if you look at the number of duty hours now, 48 hours, it actually reduces the learning opportunity for the trainees. So this is basically changing in terms of training. What else is changing? So when we were students, and basically the kind of model that was being used to train the OB/GYNs was the apprenticeship model. And in this, the student would basically be working directly and observing a skilled mentor and would be with time able to perform the task under supervision and then eventually be able to master the task and perform on their own. And this was very frequently called see one, do one, and some people would call it do one and teach one. So the model of training over the past decades has changed, and the model of training has changed from the apprenticeship model to the structured training program, which was implemented in UK in the year 2005. So this change in the structured training program has been actually a very innovative strategy to improve the quality of training, but it has its own challenges which need to be fulfilled. Now, where does the topic and my topic of obstetrical drill comes in? So basically, we know that 40% of women who are going to become pregnant are going to suffer some kind of complications. Most of them will be minor, but around 15% of women will face life-threatening obstetrical complications. Life-threatening obstetrical complications cannot be dealt with only by learning how to perform a skill. So it is very important to learn how to work as a team when there is an obstetrical emergency. And for that, the obstetrical drills or the obstetrical emergency drills need to be in place. If we have to look for achieving SDG 3, we are obviously looking at various tools and various interventions which will help reduce maternal and neonatal mortality. But we also have to look at obstetrical drills as a very important tool for reducing maternal mortality and neonatal mortality, because this is the place where we all need to be. I was going through the SAFOC countries and the Medical and Dental Council and the curriculum of the SAFOC countries, and there is something very stark in most of the curriculums for the SAFOC countries, and that was that in the undergraduate curriculum, the curriculum does not include obstetrical drills as such. If you look at the curriculum from the point of view of the postgraduate training programs, so skill development, competency-based training and skills is being talked about, teamwork is being talked about, but obstetrical drills are not there mentioned as a separate entity, and we all know that how important it is. This is just a little bit of statistic that Higher Education Commission in 2008 for Pakistan, they made it compulsory for all the medical schools to have functional skills lab. And I do know that the skill lab is going to be different than trying to teach drills to our group of residents. But this was basically the start of trying to do some work in terms of competency-based training on dummies and models in our country. Now, as I said before, that we have to link the drills to maternal mortality reduction in SDG 3. And if we really want to do that, I'm sure many of the consultants from the South Asian countries are attending the session, and some of them might not agree with me, and they would think that we are performing drills. So we are doing emergency obstetrical care drills. We are in many countries, the PPH drill of the PPH bundle approach now is being practiced. But the point that I'm trying to highlight over here is that the use of obstetrical drills in obstetrics and gynecology in many of the SAFOC countries is sporadic. It is not done as a part of the pre-service curriculum. And where it is being done as a part of the in-service training, and that too not in a fashion that it would be taken up by all the facilities all over the country. So I think that it is very important to make sure that obstetrical drill training should become a part of the curriculum. And unless we make it a part of the curriculum, it will be very difficult to implement it. Because if we make obstetrical drill a part of the medical curriculum, it will lay a very strong foundation for a safe journey for both the mother and the fetus, not only in the pregnancy, but also in the labor. Now, the question arises, do we need to talk about obstetrical drills in the undergraduate curriculum? And my answer to that would be, yes, we need to talk about that, because many of our young doctors and midwives are actually going to go into facilities where they are going to be supposed to be providing maternal and neonatal care. And a basic concept of maternal and neonatal care service provision should include the training for obstetrical drills. There are a lot of papers supporting evidence which says that for better maternal outcome, we have to ensure the obstetric drills. And I've just put in one over there to showcase the fact that this is important. Studies are available, evidence is available that drills are the way forward. Now, the question arises that what are the objectives of these obstetrical drills? As I said, that to me, it is a tool basically for achieving SDG 3. As we are looking at various other tools, we need to emphasize the importance of obstetrical drills and to ensure that in the low middle income countries, especially in the South Asian region, we are able to ensure their availability. Now, the objectives of that will be that the team will be ready and there is facility readiness for dealing with obstetrical emergencies. There's improved professional practice and teamwork. There is quality improvement, which I said is the core to any kind of obstetrical service delivery that we want to perform. And the overall, there is improvement of performance in terms of health service indicators. So obstetrical drills are going to help us go through all that. So the advantages are that we have the postgraduate trainees and the undergrads will eventually learn the individual skills. They will learn how to perform them as a team. What is the role of various people of the team? What is the status of readiness that a facility needs to have if there will be cases of emergency where obstetrical drills will need to be performed. So there are various requirements, and I don't think that we need to go into the details that exactly what are the requirements of the obstetrical drill, but I think that the most important requirement of the obstetrical drill is to have a facility environment. So the drills have to be practiced without any, first obviously providing them information, providing them hands-on training, providing them skills set, and then practicing the drills in a real life environment, and sometimes even without notice, like in a fire drill, to ensure that when an emergency happens, how is the team going to be performing? So these are the various requirements of the emergency drill and what should be done. But I would like to point out over here that in terms of drills, I think there are three very important steps. The first is obviously to create the participants to conduct the drill, and two important things which I would like to highlight over here is number one, the use of checklist. The use of checklist has to be encouraged in all the institutions, and checklist is like the holy grail for obstetrician and gynecologists when they are practicing obstetrics, and for the midwives when they're practicing obstetrics. And the second, I think, most important element in the obstetrical drill is the debriefing session. Because once we have performed an obstetrical drill in an emergency situation, we need to get sit together, get collected, discuss what were the things that we did right and what were the things that we could have done in a better fashion. If we keep on practicing these steps and implement the checklist and keep on performing the debrief, we would be able to achieve what we want to achieve. So for the Suffolk region, I think there are two very important messages before I talk about the way forward. And my two important messages are that we need to think of, for obstetrical care provision, quality of care and standardization. I think this is extremely important if we want to produce any kind of change in our healthcare structure. So for the way forward for our region is that we need to structure and institutionalize the obstetrical drills and to make sure that they become a part of the curriculum. We have to make sure that we provide pre-service training and in-service training to our young interns and make sure that they're able to do that. The adoption of drills in the form of a team approach is essential. The training has to be hospital-based. We have to ensure that these drills are implemented in various environments. So what are the various environments? So in many of the South Asian countries, in Pakistan, India, Bangladesh, I know that for a fact, and in Nepal, we have centers of various levels. So we have rural health centers, and then we have centers who are working at the level of the district, and then the tertiary care hospitals. So I think that the most important environments are the environments where the facilities are limited. So rural health centers are the centers which are trying to provide 24/7 facilities. It is essential that in these environments, the hospital staff is trained to do the obstetrical drills. And obviously, in order to rehearse the obstetrical drills, they have to take place without prior notice. Now, the questions that I identified in my, my first slide actually were that what was the importance of the obstetrical drills? Why are they needed? Are they available? And how to train for them? I think that I have tried to answer these questions in the sense that they're extremely important when we are trying to think about quality of care and reduction of maternal and neonatal mortality. And that is the reason we need them. We need them and we need to practice them. Sporadically available in the South Asian region, and training has to be mandatory, including it as a part of the curriculum, making sure that in the training program, the trainees learn. And when we are going to do the obstetrical drills, it is not only a part of only performance, but it is of learning teamwork, learning cohesion, learning coordination, developing leadership skills, and in an environment of extreme stress, being able to save the life of the mother. So just my last two slides before I end. I think the key points in this are that our ultimate aim is to reduce maternal and neonatal mortality and to achieve SDG by 2030. But we have to be aware that what are the changing trends of healthcare service delivery and also the changing opportunities for our trainees. And I think that they're extremely important, and we need to realize the limitations that we have in terms of time, the limitations that we have in terms of patient privacy, ethics, and other landmarks. And then we have to make sure that we understand that emergency obstetrical care needs much more than skills. And that is where the role of obstetrical drills come in. We need leadership, we need teamwork, facility readiness of the HR team, swift action, and the effective use of checklists if we want to make sure that we are able to save the women. We have to keep on training and we have to practice. And once the exams are passed and they are proper consultants and they are working in facilities, I think CPD plays a very important role in trying to continue to serve the cause of women of the region. So just to sum up what I said at my last slide, before anybody has anything important to add over here, to me, obstetrical drills are a tool for achieving SDG 3. Learning and implementing obstetrical drills is an essential tool for low-middle income countries, especially our region, if we want to prevent and control this huge problem of neonatal maternal morbidity and mortality. Thank you very much.
Thank you, Dr. Rubina, for taking us through the obstetric drill and letting us know how much it is important, and it can go a long way for providing a safe motherhood to the woman, and how much that is the importance of the teamwork. Thank you, ma'am. We learned a lot. And with this, we come to the end of the first scientific session. And I would like to thank Dr. Morris for his extensive talk and the insight of the initiative taken in the UK, and Dr. Leslie for taking us to the recurrent pregnancy laws, how to manage such cases, and Dr. Rubina for taking us to this obstetric drill. Thank you. Thank you, all the speakers.
Thank you.
Thank you, Dr. Jyoti. And absolutely, it was a brilliant session that we've had in order to understand the various aspects of immunology, pregnancy outcomes, and management as well. Thank you so much for the speakers. So we will be moving on to our next session today. And we have our wonderful, wonderful moderators. We have a lot of questions that we have got from our audience who have joined us today. Thank you so much for all the audience that have joined across the 7 countries. As we are running a little short on time, we will be taking up questions towards the end of panel discussion. So please keep your questions intact. The questions that you have regarding the panel discussion also, we will be taking it at the end. May I request Dr. Nilanjana Mukhopadhyay and our beloved Dr. Jaideep Malhotra ma'am to come over and moderate this wonderful session on antenatal care. We might think that, it's a very basic session, but I promise you that by the end of this session, we will know how very, very important this antenatal care is. And in case if you're able to good antenatal care, we can avoid a whole lot of other complications. Can we have the slides back, please? Yeah. Dr. Neela Mukhopadhyay, ma'am, FRCOG, FICOG. She's a consultant in the field of OBGYN at Bedfordshire University Hospitals in UK. She is also the Honorary Senior Lecturer at University College London, Associate Medical Director of Revalidation, previous Chair for Part 1 MRCOG subcommittee, examiner for MRCOG Part 3, has had several very important roles to play in the RCOG, published over 30 national and 20 international publications, edited 4 textbooks, and authored more than 50 chapters. Welcome, Dr. Neela.
Thank you very much. Good afternoon, everyone.
Yes, ma'am. Dr. Jaideep Malhotra, ma'am, again, I think the number of achievements and accolades that Jaideep ma'am has achieved in the last couple of years is phenomenal. A brilliant orator, and I would say she's someone who would kind of innovate everything, even the simplest of the parameters. She will kind of bring in a beautiful new dimension. I think one of the few things that I have to mention is the concept of an app as an all-round development for the pregnant women, that is iMoms, something that has been curated by Dr. Jaideep ma'am, a brilliant app in this world of technology, something wherein, women can open up and, look at what kind of diet they need to have and, what are the kinds of exercises they need to do and have a holistic development. That's the kind of, innovator and scientific head that we are looking at. Very privileged to have been mentored by you, Jaideep ma'am, and welcome to you as well.
Can't see Jaideep.
I think Jaideep is unable to join today.
Okay.
Oh, okay. Great. Please take over, Neela ma'am.
Am I able to share my presentation?
Yes, ma'am. Neela ma'am, would you be introducing the panelists as well, please? Yeah, if we can have the slide for our...
Yeah.
Yeah, if we can have the slide for the panelists, please. Again, I think all our 4 panelists also do not require any introduction. Dr. Deep Datta sir is a consultant OBGYN. Dr. Bhaskar Pal sir from India, Dr. Ranjana Sharma from India, and Dr. Reena Agarwal from UK. All of them dear friends and mentors along the way. So we are very happy to have you on the team today for discussing antenatal care. Over to you, Neela ma'am.
Thank you very much for this opportunity for presenting this afternoon. The topic that we have been given is antenatal care in high-risk pregnancy. And I just want to be sure we have, I can see Bhaskar, welcome, but I can't see all the other panelists. Are they here, the panel members?
Dr. Ranjana, madam is here.
Hello.
I'm here. Yeah.
Yeah, Ranjana is here.
So it's just the 2 of you, Bhaskar and Ranjana.
And you can choose a wild card entry, Neela, your call.
we will just try and connect with Dr. Deep Datta and see in case of sir will be joining, ma'am. Till then, I think you can
Leena is not joining.
Cash on the expertise of Bhaskar sir and Ranjana ma'am till then.
Sure, will do. So let me go into slideshow. No. So we've talked a lot about maternal mortality and morbidity, and we know that this is so this is absolutely so important. And as we all know that antenatal care is the care that the pregnant woman receives from organized healthcare services. And it's so important that we actually tailor it and pick up all the risk factors so that we are able to have a positive outcome to the end of the pregnancy. So the main aim of this should be to detect early factors that may heighten the perinatal risk to both the individual pregnancies and members of vulnerable groups. So we are looking at not only the pregnancy, the mother, the baby, but to a larger group of that population to intervene to improve these outcomes. We also need to educate our patients and the healthcare providers who are actually providing and receiving care. And overall, what we are aiming is to help make that pregnancy and birth a positive life experience. And that's all about antenatal care. Now, with antenatal care, it's such a huge topic, and high-risk pregnancies, we could talk for a whole year on high-risk pregnancies and high-risk conditions that we deal with in day-to-day practice. But in order to just make it simple, I will just touch upon some general, now why doesn't this move? I'm sorry, I can't move my slide. Yeah. So the next slide, I just wanted to give the introduction, and we have spoken about the mortality in some of your countries in South Asia. But the Embrace 2020 report, it gave us a good outlook on these morbidities and mortalities. We actually saw that compared with white women, the risk of maternal death was much, much higher, 4 times higher in Black women, 3 times higher in women with mixed ethnic background, 2 times higher in Asian women. And compared with white babies, the stillbirth rate was also much higher, more than twice as high in Black babies and 50% higher in Asian babies. We know that women who live in more deprived areas are more likely to die, and stillbirth rates increase with the level of deprivation and where the mother lives. And it can be as high as 47 in 10,000 compared to 26 per 10,000. So we are actually trying to ensure that we pick up these risk factors in the antenatal care and then to tailor that to improve the outcome. So I'm going to start off by asking and talking about the organization and delivery of antenatal care. So we all know that antenatal appointments, extremely important part of your antenatal care. So Dr. Ranjana Sharma, can I ask you, how do you provide your antenatal appointments to your patients? How many appointments?
Yeah. Thank you very much for including me in the panel. So you see, we know that in low-risk women, they don't need to come to the hospital for antenatal visits more than 7 times in a 7 times maybe, or in the whole 9 months. But when the high-risk group we are talking about, then the visits maybe cannot be numbered. But if you say, it can be more than 10 or even more, depending on the condition we are dealing with and what sort of support they have. In India, it's very, very different. So you see, if we would like to see patients as early as possible in their pregnancy. It's not like, at 10 weeks, 11 weeks or whatever. Because, so many things they are totally unaware of. So this is a great opportunity to talk to them, even the educated ones I'm talking about. I'm in a private practice. So you see, I may not be dealing with the masses, but, still there is so much, we see the lack of knowledge about everything about their body itself. So there's so much to be told to them. So I would prefer to see them before they become pregnant, and if not, then at least as early as possible in their pregnancy. And then if I advise them some investigation, there's no one who's going to see the investigations except me. So that's why the frequency to the antenatal clinics is much higher in India, because they have to come back to us for every little thing. So I think I cannot give a number to that. So, but if you have constraints, then at least you would like to see them early in pregnancy once to date the pregnancy. Then definitely first trimester screening, and then an anomaly scan, because some patients come from outside of Delhi where I live, but then how I plan their antenatal visits. So I would like to see them at these definite times. That after anomaly scan, then I would like to make sure that somebody sees them for growth scan, and somebody checks for preeclampsia and all that. So I can't put number to it. Thank you.
Thank you. We will touch upon that a little bit more. Bhaskar, can I ask you, what information would you give your women who have existing medical conditions? And let's talk about the very general medical conditions like hypertension, diabetes, which are the common things that we see in day-to-day practice.
Yeah, actually, there are essentially three existing common medical conditions that people in India would present with, and they are diabetes, hypothyroidism, and hypertension in that order. So essentially, we need to give them information on importance. For example, in a patient with diabetes and hypertension, we need to review their medications, whether it's a planned pregnancy and the medications were changed or the medications are safe to continue in pregnancy. If not, we need to change those medications, and we need to talk about that. For patients with diabetes, we need to talk to them about the implications of diabetes in pregnancy. And given the fact that patients who have hypothyroidism, which is approximately around 10% in our population, that their requirements for the hormones will go up, it is important to tell them that we need to check and optimize the thyroid status at the start of the pregnancy.
Thank you. And moving on to the next question, Bhaskar, and in continuum with what you have said already, what are the key factors that you would consider in recording the medical history from that woman?
We take history of whatever known medical conditions that she has. As I said, that we would specifically ask for the history of hypertension, diabetes, thyroid disorders, any other medical disorders, and thrombosis. We will take also a family history, and we'll take a history of surgical history. Recording the medical history in major parts of the country at the present moment, it is still on paper, although some of the private institutions are trying to move into an electronic patient record system.
Great. Okay. Thank you. And Dr. Sharma, can I just ask you, in terms of examinations and investigations, if you can just run through what are the main investigations you would do at booking, and then maybe around 28 weeks, and if you need to do anything else around or ultrasound scans, what is your general practice?
So I would start with a complete blood count, and then I would like to do blood group and rhesus typing, then her thyroid status by doing a TSH level, and then I would like to do her rubella IgG, and then hemoglobin electrophoresis or HPLC for thalassemia screening, and then I would also like to do a fasting blood sugar and hemoglobin A1C in the beginning, and vitamin D3. It's a very common here, a low vitamin D, and then a urine examination, routine and microscopy, and then see if there is any need to do a culture. Then I'll do a urine culture, and then this will be my basic preliminary investigations in the beginning at the booking. And then I will give them a plan then that they would need an early ultrasound scan around at 7 to 8 weeks for dating and for other things like for establishing the pregnancy. And then I call them at 12 weeks to do a double marker or whatever blood, even PLGF we do, we include that with first trimester ultrasound scan So that will be done at 12 weeks. And then I would like to repeat their CBC and urine, at least CBC, or means hemoglobin, at least once in every trimester. And if I find that they are anemic, then maybe, then I'll deal accordingly. I would also like to do the urine examination at every antenatal visit. And then I will give them, I'll ask them to come back around 20 weeks to do an ultrasound for anomaly scanning. And if they have missed the first trimester screening, then we offer them a quadruple test at 16 weeks for aneuploidy staining. After that, so investigations, basically these, unless, and yes, glucose tolerance test, where routinely, if there is a family history or there is something which directs me to do it in the beginning itself, or and then repeat, if it's normal, then repeat between 24 to 28 weeks to exclude GTM. Then if they are found to be in hypothyroidism, then we do one TPO antibodies in the beginning itself, and then ask them to do a TSH and T4 every month, and then adjust the dosage of the thyroid.
Okay.
So that's yeah.
Thank
Nila,
you.
can I come in, Nila?
Yes, please. Yes,
yeah, I think there is a special issue about India. India is such a diverse country. Means for you, it will be easier to understand. Means for the audience in the UK, is possibly we are talking of EU, and you're talking of what is your practice. It varies from country to country. So the practice varies from depending on the geography and the diversity. And anywhere in the world, if you look at what are your medical practices, the medical practices are essentially based on two premises. One is evidence and one is economics. And even in India, the situation is so diverse. So at one point of time from FOXI, we tried to come out with what should be your investigations in pregnancy. And then we had to come out with, we came out with mandatory and what is desirable. So for a vast majority of the country, our mandatory investigations are only a hemoglobin, blood grouping and RH typing, and venereal testing. And the better centers would also add to it serology, and they will add to it screening for gestational diabetes at some stage. The setups that I and Ranjana practice in, both of us are fortunate to be in a tertiary private care institute in metros, in metro cities. So we go with our whole hog of desirable investigations. I would do exactly what Ranjana said, that we will also check for we'll do a HPLC to rule out a thalassemia carrier at the booking visit if it's not already done earlier, and the rubella immunity status, apart from all other routine investigations. And TSH free and a T4 would be our basic investigations and booking whenever they turn up. In the government sector, it is difficult to offer Down syndrome screening. In the private sector, people do Down syndrome screening, and whether you go for a ultrasound and serum-based screening, or you go for a serum-based screening based on what are the resources that you have in your hand. So in most metro cities, we've now moved on to doing a first trimester screen, and along with that, we do a preeclampsia assessment screening. The only thing I wanted to add to Ranjana is that some of us have now moved on to screening for gestational diabetes, not twice, but thrice in the pregnancy. Earlier, we used to do it at booking and once between 24 to 28 weeks. And now some of us have moved into doing once at booking, once at 24 weeks, and once at around 30 to 32 weeks, because there are women who develop gestational diabetes later and might even have an adverse outcome. As far as ultrasound is concerned, earlier we used to do our, I won't say earlier, we still do our anomaly scans between 18 to 19 weeks because the official cutoff for doing a medical termination was 20 weeks. Now that it has gone up to 24 weeks, we're encouraging people to push it back to 22 weeks. The advantage is that we can assess the heart better, but I won't say that we managed to achieve moving it to 22 weeks as yet. And in the private sector, almost everybody would have a third trimester growth scan.
Yeah, so
Sure.
Bhaskar, I think, the third GTT, we depend on the growth and well-being scan. We normally do around 30, 34, 32
Yeah, I
weeks.
completely agree.
If there is polyhydramnios or something, then we do another GTT. Otherwise, we don't. Yeah.
No, but
All right,
actually, yeah, as I said, that some of us have moved into, based on our personal experiences, several of us have moved in different cities in India, have moved into doing a third trimester.
All right, thank you.
So what I'm going to do is I'm going to share with you the practice that we follow in the UK, and we are guided by our NICE guideline here, which I'll just run quickly through the antenatal appointments. And obviously, these are guidelines which we follow, but there may be some things that you may want to pick up, which could be useful in your own practice. And we offer the first antenatal appointment with a midwife, which should happen before 10 weeks of pregnancy. We recommended practices, as you said, Dr. Sharma, between 7 and 10 appointments, 7 appointments for parous women, 10 appointments for nulliparous women. And if the woman books late, then it's really key that you find out why they have booked late, because there is often a social, psychological, and a medical issue that will need addressing. There is also a key issue about interpreting services, because in the UK, we have found a higher number of women having adverse outcomes when they are unable to speak the language. So we have to make an attempt to use, interpreters and make sure that the woman understands what we are saying, and it's not interpreted through a friend or a family. We stress a lot on continuity of care so that they're getting that same care with the same midwife, and if possible with the consultant. And of course, we know that prompt communication between healthcare professionals and a multidisciplinary team approach is absolutely crucial in the care of a woman with high-risk medical conditions. And we do that quite regularly. We have established clinics where these patients are seen. Now, the information that you would give these women, and a few important things really, is we need to first clarify with the women what is their existing medical condition and how what they understand about it. We need to have the discussion about birth companion. We have to give them information about the intrapartum care, and they have to understand how their medical condition affects their care and how labor and birth can affect their medical condition, because there are certain conditions which will get worse with labor and birth, and there are conditions which will affect the baby too. And hence that kind of information needs to be clearly imparted to the woman as early as possible in the pregnancy. And taking and recording women's history, there are a few key things that we really stress on. One of them is, obviously you covered, Bhaskar, the medical history, the obstetric history, family history of both biological parents. Mental health concerns, a really important part of antenatal care, and to provide them with the support that they need. FGM is something we pick up during these antenatal history taking. Medical history about current medication, including those that they take over the counter, allergies, occupations, and any risks and concerns with occupation. For example, they might be doing something very heavy work, lifting, and they have a problem with their back or pelvic girdle, then they need to make changes to that work. Their family and home situation, particularly in relation to domestic violence, etc. Nutrition, diet, smoking, very important, smoking and alcohol consumption, recreational drug use. And you need to sometimes even look at previous health records, previous records of delivery from other hospitals if you need to plan a good antenatal care. And in terms of examinations and investigations, we have to be absolutely sure that the woman understands that she can accept or decline any part of a screening program, because this is all offered to them, and they can actually decline to have them. it's a different issue when they decline it and you as a clinician don't know what to do. But the key things in the examinations, I think, is the body mass index, very, very important to assess, because that is when you are going to assess her risk of thrombosis. You will need to do a blood test to check for full blood count, blood group, and rhesus status. You offer her screening tests for HIV, syphilis, hepatitis B, sickle cell, thalassemia, and fetal anomaly. And those are tests that are offered. The pregnant women are also offered an ultrasound scan, which takes place between 11 and 14 weeks to determine the gestational age and detect multiple pregnancies. And then this is also a screening program for Downs, Edwards, and Pataus. Between 18 and 20 weeks and 6 days, they get the anomaly scan and for placental location. And at the 28 weeks appointment, they would have anti-D prophylaxis if they are Rh negative to check for full blood count, blood group, and antibodies. And of course, if during any of your examinations you find unexpected results, then you would do a respective referral to the clinician who would be able to help. So coming on to my next question, if I can ask you, Ranjana, how do you assess fetal growth and well-being at each antenatal visit? And you can just tell me in 2 lines, what are the main things that we use to assess fetal growth and well-being?
Okay. So first is we need to know the exact gestational age. So keeping that in mind, we measure the symphysial fundal height with a tape, and if there is a discrepancy by more than 2 centimeters, then we ask them to go for an ultrasound. And ultrasound is the diagnosing modality for fetal growth restriction. Yeah.
And when would an ultrasound scan be indicated? So you're seeing this patient, and what are the few things which would trigger an ultrasound scan?
So I didn't get you. That's again.
So if you are seeing a patient and you are assessing the fetal well-being, and what would be the key things that would trigger you to say you need an ultrasound scan?
Yeah. So one thing is, the background history. If they have they have started showing signs of preeclampsia, all right, then, and if the patient has diabetes or medical disorders and also shows smaller baby on examination, and then any concern about the baby's movements that the woman tells me, then in those situations, I would like to send her for an ultrasound.
Thank you. Yes. So obviously, offering risk assessment for fetal growth in the first antenatal booking, you will be doing that risk assessment. If they have a previous history of a stillbirth or a small baby, then you would offer them growth scans at regular intervals. A symphysiofundal height measurement still remains the mainstay for measuring a fetal well-being as the first line, and you would do that from 24 weeks onwards for a singleton pregnancy. And we generally plot that onto a growth chart, which is standardized for the woman. If there are any concerns with the symphysiofundal height, whether it's larger for date or small for date, you would consider an ultrasound scan. And yes, as you said, raised maternal blood pressure, reduced fetal movements, or any other clinical findings that raise concerns, you would send or offer an ultrasound scan. Normally, we do not offer routine scans after the 28 weeks of gestations in uncomplicated singleton pregnancies. It is also really important that the woman understands that the baby's movements is very key for them to watch, and that if she notices reduced fetal movements after 24 weeks, then she must contact the maternity services. Now, these are some
Rita, I just wanted to come in and say that,
yes.
I know the NICE guideline does say that you do not offer a third trimester scan to uncomplicated pregnancy. We necessarily don't believe in that. And I know a lot of people in UK don't believe in that.
Yeah.
We still don't know what is the right time to do it, but we do offer everybody. Earlier, we used to do it around 32 weeks. Now we are talking of moving it to around a little later, to between 34 and 36 weeks.
And that is a debate that is a debate we could have on a on a full session as to when is
absolutely
when do we have these scans.
Yeah, Nilanjana, I think the UK guidelines are guided by the resources and NHS, what NHS can offer. But there is a lot of evidence that at least one ultrasound in the after 28 weeks, reduces a lot of, will improve the outcome.
Yeah, I think other than resources, the issue is cost effectiveness. Resources also is key. But I think most fetal medicine experts in UK also wouldn't agree to not having a scan in the 3rd trimester.
I agree, but I think we could have that discussion.
All right.
Let's talk about some more key important issues like venous thromboembolism. And we know that the risk of thrombosis is so high in pregnancy. How do you assess the risk of VTE in your patients that you see for antenatal care? Bhaskar?
Yeah, this has been one of our problem areas. In the sense that, it's great news that our maternal mortality ratio has fallen at least by 3-fold in the last 10 years. And that is why people are now increasing awareness about venous thromboembolism. Before that, people were so bothered about fighting hemorrhage and infection and hypertensive disorders, nobody would even listen to venous thromboembolism. We still haven't managed to make people routinely do an antenatal risk assessment. Whereas the uptake about doing a post-delivery risk assessment is increasing. So what the uptake is increasing in India is about the need for thromboprophylaxis following a delivery or a C-section. About antenatal, I think we are in a small minority who look at a risk of venous thromboembolism at the booking and understand that this is a dynamic situation, and we'll review the thromboembolism risk every time something changes, meaning if the lady develops a complication or requires hospitalization. But as we say, there's a lot of work to be done in terms of venous thromboembolism in India. But we must accept that the risk of venous thromboembolism is slightly lower in India than in the Western world. Whatever studies we have indicate to have a risk approximately about 1 in 1,500 in pregnancy, which is slightly lower than what is the risk in the Caucasian population. So it's a work in progress at the present moment.
So you did talk about, Bhaskar, about testing for gestational diabetes in pregnancy. Do you routinely test all your women for gestational diabetes?
We test all our women, and how we test our women, it varies, in the sense that everybody has got a different view. There's a group of the diabetes in pregnancy study group, and they recommend essentially from a compliance point of view that what they do is a 2-hour glucose challenge test. And they do give a 75 grams glucose load, and they test the blood sugar 2 hours later, irrespective of the fasting status of the woman. And what they accept is anything which is less than 140 is considered normal. Anything which is more than 140 means for your millimoles per liter, we just need to divide it by 18. And anything which is above 200 is considered as over diabetes. This is what they go by. There are many endocrinologists and obstetricians do not necessarily believe in this. And if it is more than 140, what they'll do is they'll do a full-fledged oral GTT by as per the WHO guideline.
Sure.
But we do this at booking. We do a glucose challenge test at booking. We do it at 24 weeks, and we do it again at 32 weeks. And if the glucose challenge test is more than 140 in the first trimester or in the second trimester, we follow it up with oral GTT. In the third trimester, we don't bother because it's too late. We just go on monitoring.
Sure. And do you do any screening for preeclampsia and hypertension, Dr. Sharma?
I think Ranjana already mentioned in the first one that they do it at 12 weeks.
Yeah,
At
so
12 weeks.
we do like the blood pressure measurement is done in
Yes.
Everyone, as we know. And we also, at the first trimester screening, we screen for preeclampsia as well.
So you're doing the
PLGF,
yes,
and uterine artery Doppler.
And you're doing it routinely on all your patients.
Yeah, means we don't do a PLGF, we just do a uterine artery Doppler. And using the Fetal Medicine Foundation software, we look at the risk rate. And if it comes to be, if the risk of developing preeclampsia before 34 weeks is high, then we put them on 150 milligrams of aspirin.
Okay. So I'm just going to run through, because I think we are running over, like with the time, we are a little short. So venous thromboembolism, we know, is 4 to 10 times more common in pregnant women than non-pregnant women. And as you said rightly, it is really important as obstetricians that we are conscious and we make that risk assessment for VTE at the first antenatal appointment. And at any other appointments they have, or if there is a significant health event during that pregnancy, and that they are then referred to the obstetrician for management. And the main things that we look at in our VTE assessment in the antenatal period is pre-existing risk factors, like a previous venous thromboembolism or a previous risk of some, if they've had, have they been positive for thrombophilia, etc. Their obstetric risk factors in terms of thrombosis, and transient risk factors, which could involve a prolonged bed bound because of a fracture or because they are unable to move, or severe varicose veins, etc. So there are various transient risk factors and obstetric factors, which are all available on the NICE guidelines, very clearly given. So if we have a few risk factors for preeclampsia, which this I think is a very nice table, and it shows that if you have more than one moderate risk factor, then taking 75 to 150 milligrams of aspirin daily from 12 weeks can actually protect the woman. For example, if it's a first pregnancy, if they are 40 or over, in terms of age, pregnancy interval for more than 10 years, BMI of more than 35, a family history of preeclampsia or multiple pregnancy. So we will measure and record the blood pressure using a validated device. And if there is any instance that their blood pressure is over 140, over 90, they should be sent to the secondary care. And then anyone with severe hypertension needs to be seen on the same day for full clinical assessment, and you would test for proteinuria. Now, quickly on diabetes, at the first antenatal booking assessment, we would make that assessment of the risk factors. So anyone over BMI of 30, previous macrosomic baby weighing 4.5 kg or more, previous gestational diabetes, and a family history in the first degree relative of diabetes, or an ethnicity of high prevalence of diabetes, which Asians would be in that category. We would offer these women an oral glucose tolerance test between 24 and 28 weeks. Now, this is what the NICE guidance says. It's not true in practice that we do it. Some hospitals will do other tests. Now, the guidance says you use 75 grams of two-hour OGTT tests. You do it for these women with the early self-monitoring of blood glucose, or you can do it in the first or second trimester and repeat it at 24 to 28 weeks if the results of the first OGTT are normal. And you would offer any woman with any other risk factors for gestational diabetes the same OGTT at 24 to 28 weeks. They have also provided us with the plasma glucose level and the 2-hour plasma glucose levels to make that diagnosis, 5.6 millimoles per liter and 7.8 millimoles per liter or above. So we do follow that, but in certain hospitals, we are also following HbA1c, which is not actually recommended, but it's much quicker to do. And so there are variations in our practice in terms of the testing for diabetes. And we do not routinely do the PLGF for our patients with preeclampsia unless we are suspecting it. In that case, if they come in with a raised blood pressure and proteinuria, then we would either do a protein creatinine ratio, or we would do a PLGF where it's available. Did you have any comments on that?
No.
Yeah, it's just that HbA1c is, if you do it by HbA1c, then you might miss out quite a lot of women with gestational diabetes. I think that's a real issue.
Yes, so that is not currently recommended, but I know some hospitals have done it, particularly during the COVID, because of the practicality of keeping somebody for 2 hours sitting and then to have to do 2 blood tests and hospital visits. So, but that's not what's recommended. We will move on quickly to some other common problems during pregnancy. And just so you know, I don't think I'm going to go through these, and I will be happy to have further discussions about other problems in antenatal care in high-risk pregnancies. But we have to be mindful that these are common things that happen in pregnancy, and we as clinicians need to be mindful that women who have quite severe nausea, vomiting, and hyperemesis are at high risk of a small baby or of growth restriction, preterm labor, and you have to be vigilant about those factors and put in place measures so you are monitoring and putting that woman under surveillance. Heartburn is a very common condition in pregnancy, and we often advise women on taking antacids over the counter, or you could give them other medication that would help them, advise them on diet, smoking, alcohol, and other things that would help. But overall, you need to be mindful that heartburn is a common condition in pregnancy, but you must examine your patient and take detailed history to make sure that there's nothing else serious going on. Vaginal discharge, a very common problem that patients present with. And if I may ask you, Bhaskar, this is interesting because a lot of women will present in pregnancy with vaginal discharge. What would your approach be when these women present?
In a normal, I think most of the times a little bit of vaginal discharge is common in pregnancy.
Yes.
And that is because of the change of the pH of the vagina. And what they need is reassurance, nothing more than that. If there is a foul smelling discharge, or if there is any pruritus accompanying, then it's a question of maybe taking a look at it and giving them some local medications. That does happen sometimes. The other important issue is that it is important to take a history that you are not missing out slow rupture, a leak, a patient leaking, that the patient is not mistaking it for vaginal discharge. So any vaginal discharge in a history of a patient who's got a history of preterm labor or premature rupture of membranes, we would be a little cautious and maybe err on the safer side to examine them. But in a low-risk pregnancy, most discharges are absolutely harmless and they need just reassurance.
Absolutely. So we can take a vaginal swab for infection, just send it off for culture if you are worried, but absolutely ensure that it's not preterm, pre-labor rupture of membranes, and there is no infection ongoing there. Do you see a lot of pelvic girdle pain in your patients, Dr. Sharma?
Neelam, I'm sorry to interrupt. We are running a little late on time, so another 10 more minutes.
Yes, we are almost.
Yes, thank you.
So pelvic girdle pain is quite common. Pelvic pain is lots of times it's posture related, and here in India there are also lots of women think they cut down on their physical activity a lot. So that is also there, but genuine, pain in the pelvic girdle, then I suggest, physiotherapy, or sometimes, supports to the pelvic girdle. And if this is symphysis pubis dysfunction, then, they really need a lot of support. And I've seen, people walking with a walker, or they are really in distress. So that can be up to this could be up to that extreme also.
Yeah. Okay, so we will move on to the conclusion, and there is a lot more that we could cover, but the decision was to keep it very general. So I think we have briefly covered on a lot of things that we can do for a good antenatal care, and in order to pick up those factors, risk factors, which are common and can lead to a negative outcome. The principles of a good antenatal care is about communication. It is about continuity of care. It's about involving the partner and the family. It's about a shared decision-making and multidisciplinary working amongst clinicians so that you are able to give that patient the right clinical care and a better outcome. And of course, there's a lot we could talk today about infrastructure and skill support and how we can improve that. But unfortunately, I think we're running out of time. So I'm going to finish here and close the discussion that good antenatal care is the mainstay for a happy mom and a happy baby. So it's really, really important that you pick up all the risk factors, take a good history, make sure you pick up all medical and previous obstetric history, and so that you are able to plan the care along with multidisciplinary team approach. And that is the key. Thank you very much for your kind attention.
Thank you so much, Heelavams. Sorry, I think my network is bad because of the rains here in Bangalore. But I think you guys have single-handedly managed the entire show beautifully between the three of you, Bhaskar sir, Ranjana ma'am, and Dr. Neela. Thank you so much for that wonderful panel. And yes, absolutely, getting back to the basics and getting it right is more important for us so that we can complications much later. I think it's safe to say that we've had a wonderful session. I would request Dr. Yusuf to take over and deliver the vote of thanks for the entire session today. Dr. Yusuf? I guess we are not able to reach him right now, but I think on behalf of the entire team of SAFOG, RCOG, and from the entire, all the nations of UK, Bangladesh, Nepal, Pakistan, Afghanistan, Bhutan, Maldives, and definitely from everyone that's there in India. Thank you so much for all the delegates for joining. A huge round of applause to Dr. Narendra Malhotra sir and Dr. Rohana sir for conceptualizing this wonderful program and collaboration between SAFOG and various team leaders across the world. Sincere thanks to Dr. Edward Morris, President RCOG, for joining us today, and Dr. Arul Kumaran sir, definitely the star speaker for our session. Rubina ma'am, Dr. Leslie, having your management skills added to the entire delegates have had a brilliant understanding about the management of obstetric drills and also how we can manage with respect to recurrent pregnancy loss. Dr. Nilanjana ma'am, you've never made us feel even for a second the absence of Jaideep ma'am, and have beautifully and smoothly sailed us through the entire aspect of antenatal care. Thank you so much to Bhaskar sir and Ranjana ma'am also for joining and showing us that, both of you are equivalent enough for all the missing panelists that are there today. And last but not the least, a huge round of applause and thanks to Shield Connect for making this event possible and for being the constant support for the entire team of SAFOG. Wishing you all a very great day or a night ahead based on which part of the world, and wishing you all the very best for the future endeavors. Thank you so much, everyone.
Thank you, ma'am. Thank you.